Good morning, everybody. Thank you for being here on a Saturday morning. And I really would like to give my thanks to the Judy Nicholson Kidney Cancer Foundation and our institution, the Sylvester Cancer Center, for allowing us to participate in this very, very nice symposium. Today is going to be a very highly educational morning, and the objectives of this symposium are to provide information and education about kidney cancer or renal cell carcinoma. And this symposium is focused on both patients, families, as well as healthcare providers. This morning, we will talk about a different range of topics in kidney cancer, from basic questions about like what is kidney cancer, what are the current treatments, what is clinical trials or clinical research in kidney cancer, nutrition, psychosocial issues, some other aspects in kidney cancer and in oncology in general that many times we do not pay attention, like survivorship in kidney cancer. And we will also have the honor to have one of our patients talking about her journey in kidney cancer. So without further ado, I would like to start this symposium. I hope you enjoy it. And there will be two panel discussions, one at 10:25 after the first three talks, and then another one at around 12:20 after the next round of talks. And I would like to encourage everybody, patients, family members, to join and also to ask questions, because this is what this symposium is for. Thank you very much. I would like to welcome Linda Ostofsky, who is the president of the Judy Nicholson Kidney Cancer Foundation. And after her, we will start our educational talks with some of our colleagues, like Dr. Janaki Sharma, who will talk about kidney cancer, Dr. Mark Gonzalgo, who will talk about surgery in kidney cancer, and I will touch a little bit on what the new treatments for kidney cancer are. Thank you very much.
Good morning, Miami. It is an honor and a privilege to be back here hosting another symposium. I would like to thank the University of Miami, all the speakers and the participants on behalf of the Judy Nicholson Kidney Cancer Foundation. Today, we are bringing the hope to you and celebrating the lives of many who are battling kidney cancer. Of course, we cannot forget about the caregivers and the loved ones who share your fight. Today, more than ever, is a time to be hopeful and celebrate as research brings more and more options for treatment with successful outcomes. Enjoy the amazing speakers today with the latest information. This symposium will be recorded and will be on the Judy Nicholson Kidney Cancer Foundation for future reference. Let's celebrate together as you are not alone. I'm praying the next year we can all meet together in person. So today, enjoy, ask questions, and get the information that's good for you. Thank you so much.
Good morning. Thank you for joining us today, and thank you to the Judy Nicholson Kidney Cancer Foundation for arranging today's event. My name is Janaki Sharma. I am an assistant professor of medicine at the University of Miami Sylvester Cancer Center, and I'm a medical oncologist that specializes in the treatment of genitourinary malignancies, including kidney cancer. It is my pleasure to give all of you a brief introduction into the functioning of the kidney and how cancer can develop in this most vital of organs. Every person has two kidneys. I should say nearly every person, because rarely someone is born with one kidney or loses the functioning of a kidney, or perhaps altruistically donates a kidney. But the vast majority of people have two kidneys. They're located above the waist, on either side of your spine, closer to the back than the front. Each kidney is about the size of a fist. And thankfully, each kidney functions independently. And it is perfectly feasible to live a normal life with only one kidney. The main function of the kidneys is to filter blood, to remove impurities, excess salts, and minerals, and to balance your hydration levels. Kidneys also secrete hormones. that control red blood cell production and blood pressure. During the course of your kidney cancer journey, you may also hear about the adrenal glands. It's two small organs that sit right on top of the kidneys, one on each side. The adrenal glands are responsible for production of many of the hormones that keep your blood pressure regulated, your stress levels regulated, and many of your essential hormones regulated. They don't typically play a role in kidney cancer, but they're often mentioned in CAT scans or MRIs, and people often ask, so I think it's good to clarify. Every day, your kidney filters all the blood in your body, not once, but 60 times. That's equal to almost 50 gallons of liquid that's pumped into your kidneys, filtered, and then pumped back out to provide your body with blood supply. From those 50 gallons that go in, the kidneys filter out all the toxins, mix it with some amount of water, and produce about a gallon of urine every day, which you expel from your body. All of this, even though your kidney is only the size of a small fist. Unfortunately, from normal kidneys, sometimes people develop kidney cancer. Cancer at a simplistic level is just normal cells that have started to grow out of control. These growing cells conglomerate together to form tumors. Tumors can be benign or malignant. Benign tumors are still abnormal cells growing abnormally, but they don't have the potential to spread. Malignant tumors, which is the ones that really concern us as patients and as physicians, are abnormal cells that grow unchecked and have the potential to spread, even outside of the kidney. So the obvious question now is, how do normal cells turn into abnormal cells? How does cancer grow? Most of our body is made up of cells. Cells are the smallest unit of a living thing. Living things grow, reproduce, and die. This is just normal. This is what cells in our body are constantly doing. They're constantly dividing to maintain our body in its normal state. In the process of dividing, the cells pick up some new characteristics, some changes every time they divide. In scientific terms, these changes are called mutations. And mutations, funnily enough, are a normal part of cell division. Most mutations are minor and don't really affect the ability of our cells to maintain our normal, healthy bodies. Some mutations are so major, our body recognizes them as unusual and potentially dangerous, and miraculously manages to get rid of those mutated cells. Over time, though, if a cell acquires enough small mutations that manage to give that cell the ability to grow independently without any concern for what the rest of the body needs, those abnormal cells multiply and turn into a tumor. Eventually, if that tumor continues to grow unchecked, it can form its own blood supply. That process is called angiogenesis. It can also start to invade the surrounding organs directly or through something called the lymphatic system. I like to think of the lymphatic system as the drainage system of the body. And that's frequently why you hear talk of lymph nodes with cancer. The cancer cells can travel through the body, through this lymphatic drainage system, and find a new home in a totally different part of the body and start multiplying there. Sometimes the cancer cells can also travel through the blood supply that they've developed. These new tumors that are outside of the kidney, sometimes close by and sometimes far, are called metastases. Those renegade kidney cancer cells that escaped the kidney and traveled through the lymphatic system or the blood vessels can get lodged anywhere. And this is actually a very challenging concept, because when a doctor tells a patient, you have kidney cancer and it is spread to your liver, the natural inclination is to think, yikes, now I have kidney cancer and liver cancer. But the truth is, if we do a biopsy of that liver tumor, it will actually show kidney cancer cells. Those are the cells that escaped from your kidney and traveled through your body and found a home somewhere else. That's why doctors can give one kind of what we call systemic therapy. And systemic therapy just means a treatment that we give through the IV or through pills orally that travels throughout your body. So that's why doctors can give one form of systemic therapy for kidney cancer, and it makes all the tumors shrink, no matter where they are in your body. Even though the tumors are in different places, it's still essentially the same cancer with the same mechanisms of growth. And while kidney cancer can theoretically spread anywhere, it has some preferred spots where it metastasizes. Lung and bone, as you can see, are the most common, followed by liver, pancreas, and brain. If that wasn't complicated enough, it turns out that kidney cancer is not a single entity. Many different kinds of cancer can form in the kidneys. Renal cell carcinoma is the most common, approximately 85% of cases. This is what most people think of when they think of kidney cancer. And this is what the majority of today's presentations covering treatment, experimental, and supportive care will talk about. But actually, you can also get urothelial carcinoma in the kidney. This is much less common. It's only 5 to 10% of cases overall. But this kind of cancer has much more in common with bladder cancer than with renal cell carcinoma, what we traditionally think of as kidney cancer. So patients with this kind of cancer will actually be treated with bladder cancer therapies, even though the tumor started in their kidney. Rarer still, you can get other totally different types of cancer, including sarcomas, lymphomas, or neuroendocrine tumors in the kidney. And they're all treated differently. Even within renal cell carcinoma, there are different kinds. Knowing the details about what kind of renal cell carcinoma you have helps doctors to plan the best treatment. So how do we tell which particular kind of tumor a patient has in their kidney? We rely upon a branch of medicine called pathology. Usually, patients will have a biopsy to take a piece of a tumor, or perhaps even a surgery to remove a whole tumor. The biopsy or surgical sample that is removed from the patient is then sliced very thinly and bathed in special dyes called stains. Each of these stains is able to highlight unique characteristics that help differentiate between one kind of kidney cancer and another. The specimens are also looked at under a microscope to look at the architecture of the cells, which also helps guide the diagnosis. The pathologist will ultimately make a decision about what kind of cancer this is. In these samples on the screen, on the left, you can see a nice normal kidney specimen. It's organized, the cells are pink, the center of the cells, the nucleus is well defined. But on the right side, you see a specimen from a patient with clear cell renal cell carcinoma. It looks haphazard and disorganized. The nucleuses, the center of the cells, are different colors, different sizes. Clear cell renal cell carcinoma is one of just over 30 types of renal cell carcinoma that have been identified. Clear cell is the most common and comprises approximately 70% of the cases. It's the kind that we have the most research about and the most treatment options for. The second most common type of renal cell carcinoma is called papillary. This is only about 10 to 15% of cases. And while we have some indications of what drugs may work better for papillary kidney cancer, far less is known about it. Other still rarer types of renal cell carcinoma include chromophobe, medullary, collecting duct, and oncocytoma, amongst others. Now that we've discussed the different types of kidney cancer and the how of kidney cancer development, I think it makes sense to discuss the why, because this is the most common and probably the second hardest question for me to answer, right after how long do I have left? And the reason it's the second hardest question for me to answer is because the answer to how did I get kidney cancer is usually, unfortunately, I don't know. The exception to this is, of course, genetic syndromes that run in families. Some of the more common ones are listed on this slide here. Aside from these genetic syndromes, There are a whole host of risk factors that have been identified, including smoking, obesity, high blood pressure, family history, toxic exposure to chemicals, even gender. Men are about twice as more likely to develop kidney cancer than women, and race. We see a slightly higher incidence of kidney cancer in Black people. But we call these risk factors because the people that have kidney cancer are more likely to have one of these risk factors than the people that don't have kidney cancer. But with the exception of toxic exposures like chemicals or smoking, we don't actually know how, or even if having one of these factors is what actually causes the cancer. For instance, in the case of blood pressure, even if you diagnose with high blood pressure and get your blood pressure treated and have it well controlled, it doesn't change the risk of developing kidney cancer. So in short, most of the time I don't know why a single patient ended up having kidney cancer. But I do feel fairly confident saying that it wasn't any particular thing that a patient did. In other words, there wasn't any particular way to prevent this. And for those that may be worried, keep in mind that kidney cancer is still really not that common of a disease. Fewer than 1 in 5,000 people are diagnosed with kidney cancer in the USA every year. Most patients have minimal to no symptoms, particularly with early stage disease. In fact, early stage disease is often diagnosed incidentally. And what that means is you may go to the doctor because you're having terrible abdominal pain. The doctor is concerned and orders a CT scan to make sure you don't have appendicitis. Thankfully, the CT scan reveals you don't have appendicitis, but it does show a 2-centimeter tumor in your kidney, a tiny thing that's not causing any problems yet, which is why you haven't had symptoms. If patients do have symptoms, the most common ones are hematuria, meaning blood in the urine, flank pain, or pain on the sides of your lower back, fevers, night sweats, and weight loss. If the cancer has spread to other organs before a patient gets diagnosed, the patient may have symptoms from the places that it has spread to. For instance, severe chronic headaches that wake someone up at night could potentially mean that a cancer has spread to the brain. Once we suspect that someone has kidney cancer, we need to figure out how advanced the disease is. This is where staging comes in. Staging tells us how extensive the cancer is. We do it because it helps doctors decide the best treatment. The most common method of staging is called TNM. The T stands for tumor and indicates the size of the primary tumor. Lower numbers, like T1, represent smaller tumors. Higher numbers, the highest usually being T4, represent larger or more invasive tumors. The N stands for lymph nodes and indicates the size, location, and sometimes the number of lymph nodes involved. Higher N numbers indicate more lymph nodes and lymph nodes that are farther away from the kidney. And the M stands for metastases and is the simplest of all. M0 means no metastases, and M1 means yes, there are metastases present. This TNM staging is used across most cancers, although there are some specifics that pertain specifically to a kidney cancer or a different organ system. After the tumor size, lymph node involvement, and presence of metastases have been codified, we can determine the stage of disease. Staging can be clinical, where you'll see a little C in front of the TNM stage, meaning it's based on scans and physical exams only, or it can be pathological. In this case, you'll see a lowercase p in front of the TNM stage. A pathological stage means that a patient has already had a surgery, and the staging is based upon the results of the surgery done to remove the tumor. Staging is usually done with the use of imaging scans. CTs, MRIs, PET scans, bone scans, they all have a role here, and each one excels in different scenarios. So not all patients will get the same scans. After we have scans done, if a doctor suspects stage 4 disease, meaning metastases, they will likely arrange a biopsy of one of the metastatic tumors, meaning the distant sites, to confirm what kind of kidney cancer the patient has. If the doctors feel that a patient's tumor is completely removable, they may proceed directly to surgery without biopsy. Once we have the biopsy or surgical sample, it goes back to pathology to figure out exactly what kind of kidney cancer the patient has. That knowledge, combined ultimately with the stage of disease, guides treatment. Stage 1, 2, and 3 cancer are almost always treated with surgery up front. Some of these early stage patients may choose to participate in clinical trials and receive some systemic therapy prior to surgery. This is called neoadjuvant treatment, and its utility is currently being explored in clinical trials, but it's not the standard of care at this time. After undergoing surgery, some patients at higher risk from the cancer coming back may get additional systemic therapy for many months after. This is called adjuvant therapy. For metastatic or stage 4 patients, treatment decisions often include further stratification based on risk factors. There are several risk scores, but the most commonly used one is called IMDC. This stands for International Metastatic RCC Data Consortium risk score. It's based upon 6 different factors, including functional status, disease aggressiveness, and some blood work values. And based on these, patients are classified as having favorable, intermediate, or poor risk disease. Treatment decisions take these risk classifications into account, as some treatments may work better for one group of patients over another. Throughout the day today, you will hear more about these different treatment options, including treatment for localized disease, treatment for metastatic disease, and clinical trial options for kidney cancer. I will conclude here, but thank you for taking the time out of your weekend to participate in a celebration of hope. I will be available later today for questions.
Good morning. My name is Dr. Mark Gonzalgo. I'm from the Desai Sethi Urology Institute here at the University of Miami, and it's my pleasure to be participating in this morning's symposium. On behalf of Dr. Mashan and the rest of the committee organizers, it's an honor to be here. And over the next few minutes, I'm going to be covering surgical options for management of kidney cancer. So when we talk about surgical management for kidney cancer, a lot will be dependent upon the stage of the tumor. When we talk about stage of a tumor, it typically refers to the size of the actual mass that involves a kidney. It can also be dependent upon how extensive the tumor is to the surrounding tissues. So a stage 1 tumor will typically be smaller than a stage 4 tumor. And along those lines, there are a number of surgical options that can be considered depending on the stage of the tumor. We have open traditional surgery. Some of you may have heard of laparoscopic surgery. And more recently, although not so recent, we've heard the term robotic surgery. The other terms I want to cover are the concept of radical nephrectomy, which is total or complete removal of the tumor along with the kidney, or in some instances, a partial nephrectomy may be utilized to remove the tumor while preserving as much kidney as possible. The evolution of surgical technique has mimicked, in large part, the evolution of surgical technology. We know, as I mentioned before, that kidney tumors were commonly removed via an open approach, meaning that we'd make a larger incision in the abdomen in order to treat the disease. Then in the early 90s and going into the 2000s, Laparoscopic surgery was pioneered for kidney tumor treatment. And then in the early 2000s, robotic surgery was being utilized for surgery for management of these tumors. Now, this just goes to show a little bit about the laparoscopic surgical instruments that can be used. You can see they're much smaller than the hand, and we would use these types of instruments initially for a pure laparoscopic surgery for management of kidney tumors. When you talk about robotic surgery, one of the advantages is that there are higher variety of instruments that can potentially be available, a little bit more technologically advanced, certainly with regard to the ability to move the instruments, and a number of options related to different types of energy or technologies that can be applied for robotic surgery. Now, this diagram shows a typical setup for when we do robotic kidney surgery. In the center is the actual instruments going into the abdomen to remove the tumor. And on the right is what we refer to as a console. This is where the surgeon sits in order to do the operation. As I mentioned, some of the key features of robotic surgery has to do with the instrumentation, but in the console, you're able to look at the field in high definition and 3 dimensions. There are certainly advantages for ergonomics from the surgeon standpoint because we're typically sitting down when we're doing the surgery, allowing us to do potentially more complex operations. And there can certainly be an application of technology with robotic surgery for simulation to help us guide better precision when it comes to the actual operation. This shows, again, an older version of the robot and the console for what a surgeon may see inside when they look into it. And this video shows how the controls for the robot can be used in order to manipulate the arms. You'll see in a moment how this can be very precise and used to do things as delicate as suturing for partial nephrectomies frequently that are involved for that procedure. This is a picture of a patient, typically how we position patients for surgery for robotic approaches. On the left side, we use instruments that are referred to as trocars in order to access the abdomen that are very small, about 8 millimeters, where the X's are shown there. And this is the actual instrumentation as we would dock it to a patient. And again, the robotic interface consists of a few parts. This is the part that is actually going into the abdomen in order to access the patient. We work with a very highly specialized team in order to do the surgery, so we don't do it alone. The instruments are carefully positioned, and then utilizing very precise tools of our choice, depending on the type of kidney tumor that's involved, we will be able to put those accordingly in order to complete the operation. I wanted to show a few examples for how we're able to help certain patients of different sizes. So this is a particular patient with what we would consider to be a larger kidney mass. I wanted to draw the attention for some signs and symptoms of kidney masses. In this case, the patient presented to the emergency room because they saw blood in their urine. So any time someone has that type of symptom, they should see their physicians. This patient also, from a urology standpoint, underwent cystoscopy to look in and evaluate the bladder to make sure that there was no pathology inside, as well as CT scans in order to help us understand, what was going on. And so after identifying this large mass in the kidney, and these are the CT scans that you can see here on the left side of the screen is really where the problem is in that kidney. And we can see here from a different view, you'll see it a little bit on the lower side here. There was a mass that was seen in this kidney. And again, the approach for this particular case was going to be for what we refer to as a radical nephrectomy, or removing the tumor. So this is a video that shows what one can see, although it's not in 3 dimensions. What we do when we remove a kidney robotically, you can see that the instruments are very precisely maneuvered inside. We had a number of different types of instruments, including staplers that allow us to handle vessels such as arteries and veins. And that was the left renal vein that was just ligated and divided. And this is the that was the left renal artery that was ligated and divided. This is the left renal vein that is going to be taken care of. And after you take care of these delicate structures with these instruments, you're able to remove the kidney intact. And so that's a surgical approach, one that is used quite frequently for management of large tumors. Again, I refer to that as a radical nephrectomy. If you look at potential guideline recommendations for smaller masses, these would be T1 renal masses. I've highlighted here, I know it's a very busy slide, but the point is that many tumors, although not all, may be managed with a partial nephrectomy, where you do not necessarily need to remove the entire kidney. I did want to highlight a few studies that show the importance of trying to preserve long-term renal function. And so this was a study done by one of my colleagues, Bill Wong, when he was at Memorial Sloan Kettering. And basically they looked at a large number of patients who underwent either radical, which is total removal of the kidney, or partial nephrectomy for treatment of tumors that were less than or equal to 4 centimeters in size. And what they found was that patients who underwent partial nephrectomy over the course of the next 10 years following their surgery were able to have a better chance of remaining free of chronic renal insufficiency compared to patients who had an entire kidney removed. So along those lines, if we're able to preserve what we consider to be good kidney, then we do our best, but again, a lot will be dependent upon the type of tumor that the patient will have, since it's certainly not applicable in all cases. We also looked at this here at the University of Miami with our team at a large national database, just to look at trends in utilization of whether or not a patient underwent robotic or open partial nephrectomy for T1 renal masses. And what we found was that there was increasing utilization of robotic approaches over the course of the years that we studied in favor of the open approach. Now, this is another case presentation of a patient with a smaller mass compared to the previous patient. Again, they were relatively healthy. This was discovered by accident. Many times patients will go for evaluation for some other type of discomfort in the abdomen and will get a CT scan. And that was the case in this patient. And you can see on the left side of the screen, which is actually the right side of the patient, that there is this spot here that's outlined by the red line, about 3 centimeters in size, showing a mass in that right kidney. And so again, viewing it on the inside, because it's a smaller mass and a bit more appropriate for what's considered to be a partial nephrectomy, we'll go ahead and identify the blood supply to the kidney. And again, the pulsating structure there is the renal artery. So a number of delicate structures that need to be handled with care prior to removing the tumor. You can see the tumor is the bump on that kidney at the top. We'll temporarily stop the blood supply to the kidney while we do the surgical excision in order to minimize the blood loss that's associated with the procedure. And that's what's happening here. These little clamps can, again, be used to minimize the amount of blood that's lost during this process. After application of the clips, then that's when we go ahead and remove the tumor, and that's shown here. At the bottom of the screen is the assistant suction device. You can see in a very precise manner, we're able to cut out the tumor while preserving as much kidney as possible. So rather than removing the entire kidney here, this would be appropriate for what's called a partial nephrectomy. Obviously, after the tumor is removed, the kidney needs to be sewn or sutured back together. We can't just simply leave it like this, and that's what's going to be shown next. Again, I think it's very interesting from the standpoint of understanding what goes on in a partial nephrectomy for patients to see what's going on. But again, because of the way we're able to do things today, that this is very well tolerated, and patients are able to leave the hospital the next day, and we'll show that in the next slide. So we use a bunch of either suture material or clips in order to control this and do what's called a very nice reconstruction following removal of that tumor. So as I mentioned, this patient went home one day following the surgery. They had very good pathology outcomes. And for this particular type of tumor, surgery is all that's needed and is a curative treatment for this condition. There's no need for additional treatment, but as I'll talk about towards the end of my talk, in combination with our colleagues in medical oncology, there are certain tumors that require what's referred to as multimodal treatment, or that is surgery in combination with any number of treatments, including chemotherapy or immunotherapy. This is another case of a patient, again, with a what would consider to be a stage 1 tumor, but similar to what we know in many other aspects, that location of the tumor is important. And in this case, it's a little bit more complex with respect to its location in the kidney. And of course, the patient would like for this mass to be removed. And if you can see here, it's very, endophytic, or what we call inside the tumor, right in the center of the screen there. It's this gray area here. I'm not sure if you're able to see the pointer, but it's going to be right in the middle of that kidney, which actually also has a stone in it, by the way. But we'll go ahead and show how this tumor, again, in this particular kidney, after taking care of the blood supply, you see the tumor there has been what we call enucleated from the kidney, and really able to curatively treat these patients with complete tumor removal and preservation of as much kidney as possible. So again, very similar to the other patient. This patient went home one day following surgery without the need for any further treatment. Now, as I mentioned, thankfully, in many cases, patients can be successfully treated with surgery alone. But in other instances, depending on the type of tumor, again, whether or not it required a radical nephrectomy, as shown here, that even after kidney cancer surgery, there are risks for the cancer to come back. And this is where we work in a very collaborative environment here at Sylvester and the University of Miami, along with Dr. Mershan and his team, Dr. Sharma and company as well, who may be here today to explore the possibility to minimize the risk of these tumors from recurring. And this represents just one particular medication that is a targeted therapy that has been discovered over the years. We recently had, and we're participating in clinical trials. I think that patients need to be educated and increasingly aware of clinical trials that are available for treatment of kidney cancer, because there are new medications coming online so frequently that it can be difficult to keep up with what is available. And this was the Prosper clinical trial that compared perioperative nivolumab versus observations in patients who underwent surgery for management of kidney cancer. And this trial is now completed enrollment, and will be interesting to see the results of this study to determine whether or not addition of this agent was beneficial. And again, it's very exciting because, as I said, even as recently as last year, there was a publication in the New England Journal of Medicine comparing yet another new medication called Pembrolizumab after nephrectomy for patients who had renal cell carcinoma. And this was comparing Pembro compared to placebo. And the observation based on this study was that there was a benefit with regard to disease-free survival in those patients who were able to receive this medication. And so, obviously medications can come with potential side effects, and that's what they had found here. But nevertheless, these results support the potential use of medications such as pembrolizumab in what we call the adjuvant setting, or after surgery, in those patients who may be at higher risk for their cancers to come back. So I think there are several take-home messages. When doing surgery, oncologic control remains the #1 priority. We know that thankfully, with the advent of minimally invasive surgery and robotic surgery, patients can do quite well with shorter hospital stays, less discomfort, certainly less time away from work, and can be very effective as a curative treatment in many cases of lower stage tumors. Appropriate patient and surgeon selection is important. Not all tumors are created equal. What I mean by that is that obviously for certain larger tumors, we may have to remove the whole kidney, and along those lines may have to utilize other combination treatments in collaboration with the medical oncologist to effectively treat the disease. And then there are many different surgical approaches that are available. As I mentioned, I really spent the most time on the robotic approaches because that in practice may be most applicable, but certain tumors may require an open approach for management. And as I mentioned before, some tumors are more appropriate for radical or complete removal of the kidney, and others are appropriate for a partial nephrectomy. And then lastly, optimal treatment of kidney cancer may require multimodal treatment. I would encourage everyone in the audience, particularly if you are dealing with this, to educate yourself. We know that research is critically important to innovate and discover new ways and better ways to treat the disease. There are so many clinical trials that are being developed and are coming online that can be used for patients to help increase chances of survival and decrease chances of recurrent. And I think it's critically important, as everyone knows and is here today, to continue engaging patients as we develop new ways to treat this disease. So with that, I'd like to end the talk. And it has been a pleasure to be with you today. I always enjoy being here with the foundation towards helping patients and also perhaps educating patients on treatment of this disease. And we're available to answer questions at this time. Thank you.
Good morning, everybody. On behalf of the Sylvester Comprehensive Cancer Center at the University of Miami, I would like to thank you for participating in the Kidney Cancer Symposium today, March 12, 2022. My name is Dr. Jaime Merchan, and I am a medical oncologist and a physician scientist at the University of Miami Miller School of Medicine and the Sylvester Comprehensive Cancer Center. My areas of clinical and research interest is in renal cell carcinoma and experimental therapeutics. And in that regard, I also act at the Cancer Center as the director of the Phase 1 program at Sylvester. Today, I'm going to talk to you about updates in kidney cancer treatments, what's new in 2022. Dr. Janaki Sharma gave a very elegant presentation on what is kidney cancer. She gave some of the important characteristics and important points to remember in kidney cancer for patients. So I'm not going to repeat what she discussed. What I just wanted to mention is that kidney cancer is a very, very important medical problem because of its aggressiveness and in many cases, difficulty in finding a great treatment for this disease. Also, it is important to remember that kidney cancer has different stages, and depending on the stage of the kidney cancer, we decide or determine the best treatment for patients. An important aspect in kidney cancer, especially when we talk about the treatments, is the importance of research in kidney cancer. Okay, years, I would say decades of research have been critical to help us understand the biology, the behavior of kidney cancer, and basically to make it simple and to summarize the decades of research, we have found that kidney cancer has two very important drivers. Okay, one important driver of kidney cancer is the tumor vasculature or the tumor blood vessels. Okay, and this is what we call tumor angiogenesis. And because of the genetics of kidney cancer, it is known and well established that kidney tumors are very vascular. They need blood vessels in order to grow and to expand and metastasize, right? And research has discovered the important components or the important factors that lead the kidney tumors to produce blood vessels and to depend on them. On the other hand, kidney cancer is a disease where the immune system plays a very important role. Okay, kidney cancer usually blocks the normal immune system of the patient that is trying to block and attack and kill the kidney cancer cells. And for that reason, okay, kidney cancer, by blocking the anti-tumor immune responses, this allows the tumors to grow. So the understanding of these very two important factors in kidney cancer has allowed the development of many treatments that target either the tumor blood vessels with pills or with drugs that target factors like VEGF, which is an important protein or factor that stimulates blood vessel formation, and also the development of immunotherapy-based treatments. And that has significantly increased the available options and has improved the prognosis in the treatment for patients with this disease. So the research over the last 2 to 3 decades has led to the development of new, better, and safer treatments for patients with advanced kidney cancer. This figure is kind of like a historical roadmap of the different treatment options available and when they were developed and when they were approved. If we can see that before the 2000s, in the 1990s, the only drug that was approved for advanced kidney cancer was high-dose interleukin-2. So some of you may have heard about that as a historical fact. Some of them may have heard of some patients or family members may have received this drug. Then in the early 2000s, from 2000 to 2010 more or less, there was the era of the anti-angiogenic agents or drugs, targeted agents that block blood vessel formation, especially block this factor VEGF. In addition to that, other drugs that were approved blocked other important pathway in kidney cancer called the mTOR pathway. And drugs like everolimus or temsirolimus were approved in that era. And then we come to the more recent era from the 2015 on, where newer options, including options that are based on immunotherapy drugs, we call them checkpoint inhibitors, either alone or in combination, were developed, were tested in clinical trials, and were approved. To the more recent, like in 2021, there was kind of like a record of the number of treatment options that were approved by the FDA for this disease. So the take-home message from this last couple of slides is that research in kidney cancer is extremely important, okay? Because the research advances, okay, in our understanding of the mechanisms, the biology of kidney cancer, how or why it grows the way it does, okay, has led to the development of these treatments that have benefited thousands and thousands of patients with advanced disease, okay? And these advances translate into better outcomes for patients with metastatic and now more recently, even in earlier stages of kidney cancer. So how do we treat kidney cancer? Like usually patients who are diagnosed with a kidney tumor or renal cell carcinoma, depending on the symptoms that they have, okay, they may go to a urologist first, okay? The most common presentation of kidney cancer is what we call an incidental finding. A patient may have, let's say, abdominal pain, and the primary care doctor may think it's gallstones or something. They do an ultrasound, and they found by surprise a mass in the kidney, right? So, and usually in these cases, the main driver of the team is the urologist or the surgeon, right? And they evaluate the patients, they look at the size, the location of the tumor within the kidney, and then they provide recommendations in terms of trying to remove the kidney tumor, because when the kidney mass or a kidney cancer is localized to the kidney, surgery is the best way to try to cure this disease. Okay, so patients who have localized kidney cancer, what we call resectable kidney cancer, they undergo surgery to remove the kidney, which is usually a nephrectomy or removal of the kidney. Dr. Gonzalgo had already presented very nicely the different techniques for resecting the kidney, either open or laparoscopic, or now more recently robotic techniques, which make these procedures much more feasible in many patients with a much faster recovery. Once patients have a nephrectomy, then is where the medical oncology comes. Depending on the stage, okay, kidney cancers that are stages 1, 2, or 3 can be resected by a nephrectomy. The medical oncologist reviews the pathology along with the urologist, and then evaluates the patient. And at this time in 2022, we, the oncologist, based on the pathology reports, based on the patient's characteristics, we decide whether the patients benefit from what we call adjuvant therapy or post-operative treatments or surveillance, okay? And this, I would say, is a moving target. The concept or the criteria to give adjuvant therapy or to do surveillance are evolving, but we have very, very clear guidelines at this time that we will talk a little bit later. About 1/3 of the patients with kidney cancer actually present with advanced disease, meaning not tumors that are localized to the kidney and potentially curable, but with tumors that have spread outside of the kidney to other organs. That's what we call advanced or metastatic renal cell carcinoma. And how do we treat them? It is both a science and also a medical art, because there are many, many factors here that will determine what the best approach, what the best treatment will be. And again, we will talk this in the following slides. Now, in terms of the post-operative treatments, in patients who have, I would say, a large tumor that was localized to the kidney and it is at high risk for recurrence, okay, remember that we have talked about 2 types of treatments. One, treatments that basically attack the blood vessels of the tumors with pills, with targeted agents, and the other one with immunotherapies. Well, because the targeted agents were the first ones to become available, many clinical trials had been done to try to determine whether these targeted agents have any role in decreasing the risk of the cancer coming back after surgery, or more importantly, if they have any role in prolonging survival without the cancer coming back in these patients. Unfortunately, many of the trials with thousands of patients that have been done have not shown a significant or clinically meaningful benefit, even though one study, the S-TRACK, showed that sunitinib was associated with some prolongation of patients being without the cancer recurring. It did not prevent completely, and it did not prolong life in these patients. Therefore, it is not considered to be a clinically meaningful result. On the other hand, the newer treatments that are based on immunotherapies are actually being investigated in different important trials. Okay, some of them, most of them have completed accrual, and one of them also has already results, which is the Keynote 564. And this study randomized patients with localized kidney cancer that had a surgery to remove the kidney tumor, and then they were considered at high risk for kidney cancer recurrence, and they were randomized to either pembrolizumab or the standard of care, which was observation. Because before these trials, okay, the standard of care for patients with kidney cancer after surgery is observation and surveillance every 3 months for the first 2 years and so on, right? So the Keynote 564 trial, which the results are shown here, was positive, meaning that patients who were randomized to pembrolizumab after surgery, again, this is not for all the patients, but patients who are considered at a higher risk as determined by criteria in the study and also criteria that the urologists and the medical oncologists know. And but this study showed that patients with high risk resected kidney cancer treated with pembrolizumab had a higher chance of the disease not coming back, right? They had some level of protection when they were treated with 1 year of pembrolizumab. And so this positive result led to FDA approval late last year. And now pembrolizumab is considered a standard treatment for patients who have kidney cancer localized and had surgery are considered at high risk, okay? And this is something very important, a very important advance in the field at this time. Now, how do we treat metastatic renal cell carcinoma? This is a little more complex because there are many, many different settings, many different situations that will affect or will determine how an oncologist treats the patients. But just to summarize, there are several potential options depending on several factors like the patient's health, clinical symptoms, how fast a metastasis is growing or not, right? But the typical approach or the typical pathway is that patients who have a proven metastatic disease, they usually undergo systemic therapy, meaning either treatments with immunotherapies, like immunotherapy combinations that many patients are aware or they know because some of them may be or may have gotten these treatments, like pembrolizumab and lenvatinib or pembrolizumab and axitinib, ipilimumab, nivolumab, or also targeted agents, especially cabozantinib. And importantly, clinical trials. Here at UM, we have several clinical trials available for most of the settings in kidney cancer, especially in clear cell renal cell carcinoma. Okay, so the most common approach is to start treatment for kidney cancer. But there are other options as well that we will talk later, like no immediate treatment, but active surveillance in patients whose tumors are growing very slowly. Or basically, if patients have just one metastatic site and nothing else, sometimes we recommend surgery to remove the metastasis, okay? And also in patients with metastatic kidney cancer, we sometimes, in very selected cases, even if they have metastatic disease, we may recommend or consider surgery to remove the kidney mass. Okay, this is somewhat evolving as well, and this, especially in the era of immunotherapy agents, this is something that will probably change, and new guidance may come in the future. This table is very important, a very important tool for the clinicians, because this is based on clinical criteria. For example, from the hemoglobin to see if the patients are anemic or not, the calcium level, platelets, white blood cells, and so on. These criteria, we always check the patients at the beginning before we start any treatment. When we tell the patients we need to do blood work, chemistry, etc., and do a history and physical exam, these 6 criteria help us determine whether patients are a favorable risk, intermediate risk, or poor risk, okay? Depending on how many of these factors they have. And this is very important because when we stratify our patients based on what their labs show and the clinical exam shows, this tool, this table, gives us some useful information on the aggressiveness of the tumor, on the prognosis, and what the best treatments may be. So this is how we more or less approach a patient with advanced disease. Again, we evaluate the patients with metastatic kidney cancer, we check the labs, physical exam, and then we determine whether they belong into the favorable risk, intermediate risk, or poor risk. And based on that, we determine the best treatments, okay? In many academic institutions like ours, some of the best treatments include clinical trials because they are testing new treatments or new combinations of drugs that are very promising or proven to work in kidney cancer. When there's no clinical trials available, okay, the combinations of immunotherapy agents and targeted agents are very, very appropriate, as well as in patients, for example, with intermediate or poor risk, combinations of immunotherapy, of two immunotherapy agents like ipilimumab and nivolumab also are good options. So there are many options that the clinicians have to choose from, okay? And we have tools, especially clinical tools at this time, in order to try to determine the best treatment for the patient. How about patients with non-clear cell renal cell carcinoma? As Dr. Sharma mentioned in her talk, not all kidney cancers are the same, okay? The most common subtype of kidney cancer is one that we call clear cell renal cell carcinoma, which occurs in about 3/4 of the cases. And in 1/4, there are the other types of kidney cancer called non-clear cell renal cell carcinoma. And basically what we have available, okay, is clinical trials, and also some drugs that have been shown in clinical studies, recent clinical studies, that to have activity in non-clear cell RCC, especially in papillary kidney cancer, which are, for example, cabozantinib. And there are other combinations that are approved for clear cell renal cell carcinoma that we use sometimes. But again, the preferred approach, if available, would be a clinical trial, because these are rare tumors, and we can only find the best treatments if we do clinical studies and research in this. So how about other alternatives that do not include treatment or drugs? Okay, as I mentioned in the like 2 or 3 slides before, one option is to remove by surgery metastases, especially in few selected patients who have very, very few, maybe 1 or 2 metastases in the same area, and is safe to do surgery, right? Other option includes watchful waiting, which means no treatment or no surgery. And how would you know that a patient would benefit from this watchful waiting? And what are the advantages of that? So usually the common case of this is for patients who, for example, have a very, very small nodules, let's say, in the lungs, just to put an example. And they're small, and over time, we're seeing that they're not growing, or they're growing very, very slowly, maybe 1 or 2 millimeters per year, something like that. And patients are doing very well and asymptomatic, right? It has been shown in some retrospective studies that this approach, watchful waiting in these selected, very selected patients, this is not for everybody. And the medical oncologist who specializes in kidney cancer would be the best professional to try to guide or to discuss with the patients if they are those very selected patients. But some studies have shown that this watchful waiting in tumors that are growing very, very slow, not starting treatment right away, does not make any difference, or is not harmful in the sense that it will not lead to resistant tumors or things like that, okay? So again, this is not for everybody, very, very selected patients, and only the doctor taking care of kidney cancer patients would be able to determine if this would be an appropriate option for a specific patient. What do we consider as factors for first-line treatment? Okay, so first, one size doesn't fit all. This is very critical. Each patient is unique, and the oncologist needs to determine and design the specific treatment for a specific patient, timing of the treatment, discuss the side effects, etc. There are multiple factors that we as oncologists determine, like, for example, the patient's overall health, if the patients have other medical conditions, like, let's say, diabetes or high blood pressure or heart disease, right? How fast the cancer is growing, and also patient preference, because we have several good options, okay? And sometimes two options may be good. And when the doctor discusses side effects of option A or option B, the patient said, I would prefer this option because I would not be able to tolerate this specific side effect, right? Also, some factors are tumor related, whether they're clear cell or non-clear cell, where the metastases are, like in the bones versus the other organs versus the brain. And also, it is very, very important to mention this, that experience by the oncologist counts in the treatment of renal cell carcinoma. So, Dr. Bilusic is talking about research in kidney cancer, and I'm just going to mention some very briefly about the importance of ongoing research. This slide shows all the different immune cells that can be potentially targets of treatment for kidney cancer. And you can see a lot of cells and a lot of different targets and different drugs that are being tested in kidney and other cancers as new forms of immunotherapy. So this is very exciting. And also, more specifically for kidney cancer, there are some drugs that are advancing in the field. For example, one drug called belzutifan, which is a blocker of hypoxia-inducible factor 2A. We at have been very important players in the development of this drug from the beginning. And this is a very promising drug. However, it is not FDA approved yet for every patient with kidney cancer. This is a drug that has been approved for kidney cancer that is associated with a genetic syndrome called von Hippel-Lindau disease. So, and this can be used in those patients. There are phase 3 studies that are actually advancing and enrolling patients combining this drug with immunotherapy and with targeted therapy. So this is a very exciting drug that will probably make a big difference and will be a very important addition in the armamentarium that we as medical oncologists have to treat kidney cancer. Other options that we at are investigating are the effect of oncolytic viruses, which are viruses that treat cancer, that have been specifically designed and re-engineered to be more specific to attack tumors more than normal cells. They infect, spread in the tumors, and they kill the tumor cells. And in addition, they stimulate or induce the immune system of the patient to also attack the cancer. So these are very, very promising and exciting area of research. So in conclusion, we can say that the state of the field of kidney cancer is very, very strong. And there's a lot of hope because of the options that there are that have been approved, and also the active research that is being done here at at other centers. Significant progress has been made in renal cell carcinoma treatments, like the new immunotherapies, combinations of immunotherapies and targeted therapies, which have significantly improved the prognosis for many of our patients. Okay, and the immunotherapy and targeted strategies, I wouldn't say may change, but have changed the standard of care in first-line kidney cancer, because now we're using immunotherapies at the beginning, early on in the first line, okay? And there are many other agents that are being studied in research that also will bring a lot of hope. And finally, it is important again to emphasize that experience counts when treating kidney cancer. So it is important that you as patients ask your oncologists about their experience in kidney cancer and ask questions. Like a physician who knows, who is an expert in kidney cancer, will not mind being asked questions about kidney cancer and its treatment and what our opinion is. Okay, so don't be shy. You have to ask questions, and you have to also do your due diligence to make sure that you feel comfortable with the professional who is treating you. who is preferable to be an expert in kidney cancer. Now, what are the future directions and the needs? Okay, we need to improve individualizing the treatments for kidney cancer. There are many treatments, and each patient is unique. Okay, we have improved in the prevention of recurrence after surgery with immunotherapy that was approved last year. And we always need better treatments for the less common cases of non-clear cell kidney cancer. That is a medical problem. And we here at UM and other centers, we understand that this is a problem and are trying to put our efforts, okay, to do more research in this less common type of kidney cancer. Okay, in spite of all the advances that we have done, there are some patients who still have tumors that are very resistant to treatment and unfortunately succumb to progressive refractory disease. Okay, and this is again is a big important call, and I cannot stop talking about this. That research is so important in trying to overcome this resistance and these problems that we are facing every day in some patients with kidney cancer whose tumors, okay, it's not the patient's fault or the doctor's fault or even the treatment's fault. It is the nature of some kidney cancers that are so aggressive, okay, that do not respond to the very active treatments that we may have. And this is why we need to continue our research, and we need to continue support and push the government authorities to provide more research dollars to the investigators who are trying to improve the outcomes and prognosis in these patients. So I cannot stop emphasizing the importance of research in kidney cancer and the importance of we as physicians and also patients and patient advocates to keep pushing the authorities, the government, foundations to support kidney cancer research, because this is the only way where we can actually help cure patients. So thank you very much for your attention. This is the end of my presentation. The take-home messages here is that there's a lot of hope in the treatment for kidney cancer. The research in kidney cancer is advancing very fast, and this is a very good thing, because that ensures that there will be always new treatments and new hope for patients with kidney cancer. And I would be happy to answer any questions in the question and answer session later on during the day. Thank you very much.
Hi, my name is Raquel Cousler. I'm 54 years old. I was diagnosed with kidney cancer back in 2012. I had just traveled back from Israel with my husband to see his family. And I noticed actually the day of my travel that I had gross hematuria, which is urine in the, blood in the urine. And I noticed that it was kind of odd. I had not had any symptoms. I didn't have any pain or anything. And so I was kind of worried. And as soon as I got home, that was the end of December. That was December of 2011. I immediately went to see my primary doctor, and he ran some tests. And then it was towards the end of the year, and he didn't get back to me until the beginning of the year. At that point, I still had blood in my urine, and he decided to do some other tests like an MRI. When we got the results back from the MRI, it showed that I had a huge mass on the right kidney, and it looked to be contained. So it was maybe the size of an orange. And at that point, he called me into his office and he says, I need to speak to you. this doesn't look good. I'm going to send you to a specialist, to a urologist. I went to a urologist and he ran more tests, and yes, it was cancer. That was when I first heard the word cancer. He ran more tests, this time an MRI with the contrast. And when I went back to see him, basically he has said to me during the previous visit that he had to perform surgery, that basically they just had to take out the mass and probably take out the right kidney because it was contained, it was so large. When I got the results, when he saw the results of the MRI that had the contrast, he noticed that the cancer was spreading to the vena, to the renal cell, to the renal vein, to the main vein, the vena cava. So it had traveled the renal vein, and then basically it was going up to the heart. He told me that was a very complicated surgery, and that while his mentor was still alive and performing that type of surgery, that he was going to refer me to his mentor, which is he's Dr. Gaetano Ciancio. He's the one that performed surgery at Jackson. So basically, that was the time that I got diagnosed with stage 4 cancer. And so I had the surgery in January of 2012. It was a very complicated surgery. I survived, obviously. I'm here to tell a story. I was in the hospital for 5 days, and I think I recovered quite quickly because of the fact that I was always very athletic. I used to run marathons and do triathlons. And I think that I could attribute my recovery due to that I was very fit, and I was very thin at the time. I was there for 5 days, and then I got released from the hospital. It took me about 3 months to just fully recover. I would walk a lot just to gain some strength. And basically the recovery was just very passive. I didn't feel bad at all, other than mild pain, but I guess that was after such a invasive surgery. That's normal. And I went about my life. Because of the fact that it was cancer and it was stage 4, I was recommended an oncologist at Sylvester just to follow up scans after 3 months, every 3 months. I did that. I started going to Sylvester and do scans for the chest, the abdomen, and the pelvis. And I was doing them every 3 months. In 2013, during a normal routine scans, and then I see the oncologist, he had told me that the scans, he had seen spots in my lungs, and that probably that would be metastasis of the cancer. He wasn't sure at the time because I had to have a biopsy done. But basically, being that it was stage 4, and I had not had anything show on the scans during the prior 13 months, and now all of a sudden I had spots, it made them believe that it was metastasis. At the time that I saw this doctor, I didn't get much hope as far as survival because of the medicine that they were using at the time. my only option was to do a treatment called interleukin-2, and it was going to be very aggressive, very toxic. It entailed me go to the hospital every day. I would go in on a Monday, check out on a Friday, and this would continue until first of all my body could stand it, and if it could stand it, it would last about 9 months, and that would not give me basically I had 5% chance of survival. When I heard that, it scared me. I couldn't believe that I was hearing that. I had already processed the diagnosis of cancer in stage 4 and having a major surgery. That happened so quickly. I didn't have any time to process all that. I feel that the people that were really affected by it was my family, my husband, my sister, my niece, my brother, those around me that are close to me. They suffered more than I actually suffered, because it's something that when it happens to you, you sort of build a shield to protect yourself. And I couldn't really believe that I had cancer and that I was going through all that. But it really shocked me when I heard from my oncologist at the time that there was nothing other than interleukin-2 for my treatment. That was July of 2013, and my husband and I decided to start doing research and trying to find a way out of this, looking for any chance of survival other than this treatment. Maybe do holistic things or herbals, or we didn't know. We just started doing research, trying to find out what was out there. At that July, that was July of 2013. We were supposed to go to Israel to visit his family once again, and my husband started doing some research, and he came across this physician, not physician, but he was a scientist that developed a device that you would blow oxygen into it, and it would detect what kind of cancer you had. My husband got in touch with him, and he said, listen, we're traveling to Israel. My wife has been diagnosed with stage 4 cancer. It's metastasized, probably has metastasized to the lungs, and we want to know what kind of cancer this is in order to know how to treat it. We went to Israel. We met with a scientist. He referred us to a thoracic surgeon in the University of Tel Aviv. And I met up with him, and I had taken with me all the slides, all the reports from the surgery, from the radical right nephrectomy that I had in January of 2012. And basically his opinion was that I would have to dissect all those tumors from both lobes, that there was nothing else that they could do. So he referred me to 2 doctors, one in New York in Mount Sinai and another one in Boston. So we came back from Israel already with the mindset that we were going to have surgery, and this was not going to be fun. Probably it was going to be in either New York or Boston. So we reached out to both doctors and decided that it would be best for us to do the surgery in Mount Sinai, New York. I was just going with the flow. I said, okay, if I have to go to New York and have my surgery, then I'll have surgery. At this point, I wasn't in control. I was just I was relying on my husband a lot, 100%. I was trusting him that he was going to help me do the research, get the right doctor, because at this point I couldn't handle all of that, all this news of having to dissect my lungs, and I didn't comprehend very well what was going on. And my husband has a friend that called him and told him that he knew of someone that had a couple of properties in the New York area by the north, the Upper East Side where the hospitals are, and that she could be a good help for us to find an apartment and maybe rent for a month or two. We didn't know exactly how long this was going to take, but that we could get in touch with her and she would be able to help us. So my husband got in touch with her, and long story short, he was very open with her, and she said that to hold off, that she was going to speak with her brother, because her brother is he's an oncologist at Sloan Kettering, and his very good friend, is the specialist for kidney cancer at Sloan Kettering, and she was going to try to help us with, as far as getting a second opinion, because we hadn't really gotten a second opinion. So this lady was kind enough to help us with that, and she got me in touch with my oncologist at Sloan Kettering, and that's how I got to be there. I took many trips that year to New York, went back and forth, finally had the diagnosis, and it was stage 4 kidney cancer that had metastasized to the lungs. At that time, I became his patient, and of course he wondered why I live in Miami and what am I doing in Sloan Kettering. And I mentioned to him that the oncologist that was assigned to me at the time, the only solution that he gave me for my treatment was interleukin-2, and that it was very toxic, and I just refused to undergo such a toxic treatment and only 5% chance of survival. I felt like it had to be something else out there for me. And this doctor told me that he had stopped using interleukin-2 in the 80s, and that there were other drugs out there, other treatments available for stage 4 kidney cancer. So I became his patient, and I was under his care. And he recommended somebody in Miami, because I live in Miami, and he recommended Dr. Merchan, because they're friends, they know each other. And that's how I got to Dr. Merchan at Sylvester. So I started with a treatment in November of 2013. That treatment did not go very well. I was only able to take, it was an oral pill for like 8 days, and it actually sent me to the hospital. I developed a really bad rash all over my body. And so I stopped that treatment, and my doctor in New York told me, well, we'll start something else in January. So in January of 2014, I started with Sutent, and I was on Sutent for about close to 5 years. At that point, I started seeing Dr. Merchan here in Miami. So I would do the scans in New York, and I would do a follow-up with both doctors in New York and here in Miami. And after 4.5 years on Sutent, my doctor decided to change the treatment. Apparently the tumors were under control, but they had not gone away. I was told that kidney cancer is very stubborn, and it's not something that you go under into remission. It just, there's no cure. And so it's a constant treatment that can last for years, for the entire life. So in September of 2017, my doctor told me, okay, we're going to start on Opdivo. This is a new drug, a new treatment. It's an immunotherapy. And basically, when you start the first few months, you do not get a good indication of the results of the treatment, because it tends to, everything gets inflamed, swollen. Like if the tumors that you have, if they're small, then 3 months after the scan, they would show probably a little bit bigger than they actually are, but that's just normal until you have enough, you give it time, and eventually you'll get a good indication of how well the treatment is going 6 months into it, 6 months into the treatment. When I started that, it was September 2017, and I guess it was just the change. I started feeling all kinds of pain all over my body, in my joints. I was swollen. I was very uncomfortable. I had pain in my feet. It hurt me to stand up, to walk. And it was very, very painful. I followed up with Dr. Merchan, and he said, Raquel, if you're not comfortable, we could always stop the treatment and we can continue until you feel better. This is about quality of life and not quantity of life. So whenever at any given point we have patients that are going through pain, we encourage them to stop the treatment until they feel better, acquire some strength, and then continue on. So after hearing that, of course, I'm very stubborn. So I decided I'm gonna go through with, it doesn't matter if I have pain, I'll deal with it. I don't care. I just want to give this 6 months and see if it works or not. So at the end of December, it was 3 months that I was doing Opdivo, the Opdivo immunotherapy. I went to New York and I had my scans, and I was already ready, thinking, okay, I'm gonna have scans, the tumors are gonna appear larger than they are. Well, to my surprise, they had decreased by 30%. And I couldn't believe it. I couldn't believe that. In my case, instead of augmenting, they had actually reduced by 30%. So I was so excited. I was so happy. I really was hopeful that this treatment was going to be the one for me. This treatment doesn't have that many side effects, and I was happy about that. Besides the fact that the first month I started feeling pain and all that, but I think that it was just my body, it was shocked. It was, now you stop this treatment for like almost 5 years and you had all these horrible side effects, horrific side effects, and now you're all of a sudden starting something new. Your body doesn't know how to react, and it's just, everything was swelling up. So it was, of course, I had pain in my joints, but I said, I'm gonna give it a shot. And so after the 3 months that I got really good news, I said, okay, I'm pumped up. I'm gonna keep doing this treatment. And so I did. And then after March of 2018, March 2018, that was my second scan. That would have been 6 months after immunotherapy, after Opdivo, being on Opdivo for 6 months. When I got the results, my tumors had reduced by 50%. It was incredible. And after that, June 2018, you could barely see any tumors in my lungs. It was just like microscopic, like scar tissue. And so ever since then, I have been on Opdivo, and it's been great. I don't feel any side effects. My scans show no new growth. Everything is stable, and I'm doing great. I live my life as if I don't have any cancer. I try to be very positive. I try to do everything like a normal person would do: go to work, walk my dog, exercise, cook, clean, go out with my friends. If I have a little bit of pain, I just suppress it in my mind. I just feel so blessed that this treatment in particular has given me hope for a long life, living with stage 4 kidney cancer that is metastasized to the lungs. This disease can also metastasize to the brain, to the bones. Luckily, I've been following up. I do brain scans every 2 years, and I do a bone scan every 3 years, and so far nothing has shown on any of those tests. So I just feel very blessed, very happy that there's this treatment for patients like me and for other patients that are in the same shoes as I am. I say to those patients, those people out there, women, men, children, that are fighting, to keep fighting, to not give up, to always have hope that there's a cure, that there's a treatment, that the mind is such a powerful tool, and that it can be healing. Your mind can heal you. I believe that. And when I was in my darkest moment, and I didn't know that there was going to be a treatment for me, that I was going to survive this disease, I kept so positive, because you're fighting for the people that are around you, your support system. Believe me, it's harder on them than it is on yourself. You just have to think positive. You just have to believe in your heart, believe in yourself, believe that there's a cure, that you're going to overcome anything that comes your way. I believe that 100%. That's what got me through this journey. There's a cure for everyone. I truly believe that. That's how I've gotten through this hard journey of stage 4 cancer. And I'm still fighting, and so can you.
All right. Well, we're having a little bit of technical difficulties, but we'll work through that. I'm not sure if everyone can still hear me, but we'll try to go through this, and I'll try to do our best with going through the questions that are in the comments section. So go ahead and do that. And at any time, please, Jim, feel free to bring back Dr. Mershon, as I know he is really quarterbacking this program. So the first question that goes on the list here, let me look through the comments here. And I'm not sure if Dr. Mershon had this, but forgive us if we repeat this. As a complete responder to high-dose IL-2 post a 10-centimeter tumor and hundreds of small metastases to the lungs, obviously she's an example of an excellent response, which has now been durable. And I think that was the response to the question. Not all patients respond, but I have not taken any medication. So it's a viable option for patients with an experienced physician, particularly those patients who have advanced disease. And that was, again, in response to the question specifically of what can doctors do through the foundation to require insurance companies to give patients with the treatments that doctors believe are appropriate. So I think, that addresses some of the needs that people may have with regard to their specific treatment plan. And again, to try to use resources such as the foundation to find out more about that. Certainly, I think there can also be a lot that may be available with patient advocacy groups to help you get the best treatment possible for your tumor. And again, I think also it points out whether it's insurance issues or even just basic information out there about how you could get your particular situation managed, whether it's through surgery or even availability of clinical trials. So there's, I think, sometimes a lot of information out there that patients may not even be aware of, that through resources such as the foundation that can help guide you. So we'll look again at the comments, and I don't have anything here right now. Okay. All right, and Linda, I think we had that. Okay. Yeah, again, I think it's related really to, I guess, at least the one question about what can they do for insurance companies. Dr. Sharma has joined us, so perhaps she can address this, because I think a lot of the insurance challenges that people face may actually be related to a lot of the newer treatments that are out there that as an oncologist you may see.
That's absolutely correct, Dr. Gonzalgo. Linda, I appreciate your question, because I think a lot of patients feel that the insurance companies are dictating treatment. And what I can tell you as someone that provides a lot of systemic therapy for kidney cancer patients is that sometimes we do get pushback from insurance companies, that the treatments we recommend are not what they deem appropriate. But I would say that 99% of the time, I'm able to contest the insurance company and proceed with the treatment that I find appropriate. Where I think foundations really come in is that sometimes the insurance companies will approve treatments, but due to the high cost of the drugs, patients end up with copays sometimes in the thousands of dollars every month. And so we rely upon private foundational assistance. Sometimes drug companies themselves can provide assistance to cover the cost of those copays, reduce the cost of those copays, provide copay payment cards to make treatment affordable. It's really a twofold problem. And at Sylvester, we have a robust back office mechanism to provide all the support and the financial support that patients need to get access to the treatments.
Great. Thank you, Dr. Sharma. I'll read the next question there. I'm not sure if you can see it in the comments, but the next question, again, can immunotherapy treat metastatic, or I would assume metastases in different locations?
Another great question, Carrie. And we're absolutely confident that immunotherapy can treat metastases in different locations. And not just immunotherapy, but some of the other systemic treatments that we have, like Dr. Mershon talked about, treatments targeting the blood vessels, tyrosine kinase inhibitors. These oral therapies and immunotherapies work on kidney cancer wherever it is. And one of the beautiful things about immunotherapy is that although it's not all patients, some patients get complete responses from immunotherapy that last for years, even after we stop the immunotherapy treatments.
Great. I'll read the question for everyone in case they can't read the comments. Again, from Linda. There is a trial comparing systemic therapy before the anticipated surgery, hoping to shrink the tumor or avoid it altogether. Are there many patients who can avoid surgery altogether? What factors go into this decision? So again, I'll answer at least from a surgeon standpoint, and I'll have Dr. Sharma, and also we have Dr. Belusik and Dr. Mershon now joining us, because remember, anytime you approach this, particularly when you're involving multiple specialties, and as you said, the combination of immunotherapy or surgery, we all talk as a team, right? Because everyone is important. Typically, it's not necessarily standard of care to initiate systemic treatment prior to surgery, but as pointed out here, there have been trials to assess relevance of these new types of agents into the whole process of trying to provide maximal control of the tumors. And while the answers are not out there yet, there is at least one, if not many more trials that are exploring the issue of and timing of these agents, either before surgery or after surgery. And I don't think necessarily when you're enrolling in the clinical trials, depending on the trial, that you're trying to avoid the surgery per se. That is not the case to avoid surgery if you're trying the immunotherapy, but hopefully to optimize the outcome as it relates to surgery.
I would agree with Dr. Gonzalgo on this. Oh, Dr. Mashan, if you're available, this is a great question for you.
Yes, sorry, there was a technical problem and I couldn't hear the last part, but I'm looking at some of the questions here and I think some of them have been already addressed, like can immunotherapy treat metastatic in different locations? I think Dr. Sharma, you addressed that. I think there was a question about systemic therapy before surgery. Was that the question, Dr. Gonzalgo?
Yeah,
so
that's where, and we're following up on, I think specifically, you can address specific trials if you like. Also, are there many patients who can avoid surgery altogether?
Yeah, well, that's a great question. And in my opinion, it depends on the setting, on the clinical setting that we are facing. Okay, so one question would be in patients who have localized small renal masses without metastatic disease, and whether they can be managed or just monitored with watchful waiting, right, without any surgery or any systemic therapy. And second, in the setting of patients who have advanced or metastatic disease, who had the primary tumor in place, as to whether there's a role of surgery in those patients. So I'm going to talk about the second setting, and I would like Dr. Gonzalgo comment on the first setting about solid isolated small renal masses. But in the second setting, there have been studies, more recent studies, asking the question as to whether is there a role for surgery in patients with metastatic disease. And so this is a moving target, and there's no clear answer yet. But the most recent research has suggested that probably in patients who have metastatic kidney cancer with a lot of metastases, or patients whose clinical condition and health is not the best, okay, those patients may benefit from starting with systemic therapy first, either immunotherapy or immunotherapy combinations, while surgery to remove the kidney mass in patients with metastatic disease can be done in very, very selected patients. For example, patients with very, very small number of metastases, patients who what we consider favorable or good risk, okay? And that, again, is a decision that is made multidisciplinarily with the urologist, with the medical oncologist, and with the patient. And how about Dr. Gonzalgo, the approach or the decision as to whether to operate or not operate small renal masses, because you in your practice probably have a lot of those patients, right? And then you have to discuss with the patients the benefits and risks of doing surgery versus observation.
Right, Dr. Mashan, and that's a very good point. And I touched upon it a little bit in my talk earlier this morning. Certainly, kidney tumors can come in all different shapes and sizes. Some are confined only to the kidney, while others have obviously spread. And surgery may not necessarily be indicated for all types of tumors. And those tumors that are small enough, again, depending on your health status, your age, and other factors, may not need surgery at all and can be safely observed. We know that in general, some tumors tend to grow very slowly, and your risks of having any harm from the tumor may actually be small. And again, this would be for those tumors that are relatively small. And then lastly, as an alternative to surgery, for management of some of these masses is a technique known as ablation, where an interventional radiologist can actually freeze or burn the tumor. And we've shown, at least the literature has shown, that the treatment for freezing these masses can be just as effective as surgery in the right setting. So if you are not a person who wants to have surgery and someone who does not feel comfortable just observing or what we say surveilling these smaller renal masses, that may be an option as well.
Okay, so we are a little bit behind time, but I will read one more question, which is an interesting and kind of controversial question. The question comes from Joel Stern. The use of THC, which I assume is tetrahydrocannabinol, and immunotherapy. Recent studies show that use can affect efficacy of immunotherapy. Any thoughts? Appreciate that THC treats anxiety, stress, depression, sleep, but it impacts immunotherapy. Doctors should be telling patients. Dr. Bilusic, what are your thoughts on that?
So it's a great question. I have quite a few patients asking that, and it's coming in the literature. So each time you have something in the studies, testing on animals or small phase 1 study on 10, 20 patients, it's just hypothesis generating. And we are not allowed to promote that unless we have a strong research to support recommendations. So in order for treatment to be recommended officially, it has to go valid clinical trial with control arms on hundreds of patients before it becomes something standard of care. So I did lots of early phase studies, and you have all these interesting findings that you can talk about, but official recommendation and is not something that we can say, well, one study show in some patient we can do that. So and for the research before it becomes mainstream and recommendation has to be confirmed with some other groups. And it takes some time to do that. I know that a lot of patients, they take a lot of alternative medication, and we talk about it. I'm not completely opposed, but I just want people to understand that sometimes can make you feel better, and that's the important thing. But what is really anti-cancer activity of this particular agent, it's still being investigated.
Thank you. And there's another important question that talks about one of the issues that we discussed, which experience counts. Okay, there's a question from Kelly asking, how can we, family member of patients with kidney cancer, how can we help get the message out to seek an expert in kidney cancer if you are diagnosed? Raquel's story is so powerful, and it seems like so many people accept the first offered treatment / prognosis, which are often decades-old protocols, or no treatment at all, like was my brother's experience. Getting patients to experts seems to be critical for their longevity and quality of life. Dr. Sharma, your thoughts on that? What would you recommend, or what is your take, and what would you tell the patients?
I think going to an expert is to help guide your treatment is always important. It's your loved one, and you want to make sure that they get the best care. But there's also a value to getting treated close to home in an area where you are comfortable and where you can easily access treatments. And so one of the options that you have is to always get treatment with a local oncologist and consult with an expert at a regional cancer center. NCI designation, can yield to a certain level of patient comfort with the cancer center, knowing that you're going to some of the best places in the country. It can also help connect you to kidney cancer experts who may connect you to clinical trials that give you the latest treatments that are more promising than standard of care therapies. And so, I would tell patients, do your research, go online, look at NCI designated cancer centers, and see who really is an expert in kidney cancer, who's talking at national talks, who are the thought leaders around the country, and potentially go to treatment for them. And if that's inaccessible to you, you can always do telemedicine consultations or one-time in-person consultations to get more information.
Thank you. And the last question for Dr. Gonzalgo, can ablation, either heat or cryo, be done at any location in the kidney? Are there limitations?
Yeah, so I'll say that there are limitations, similar to real estate, location of the kidney tumor is very important, and that may make one technique for managing it more favorable compared to the other. So there are tumors where, depending on the situation, a surgery may be preferred as opposed to ablation. And this relates to another comment, again, that was in my talk and also in the private chat, which I'll loop into this about, what are determinants of whether it's a partial nephrectomy versus a radical nephrectomy for a patient. And again, these are potentially very complex issues, and you may get different answers. And again, roped into the earlier point, I think, this reinforces or emphasizes the importance of seeking out experts, not only in surgical treatment for the kidney cancer, but also, from an oncologic standpoint with medical oncology and availability of clinical trials and everything that we've talked about this morning. So again, it's important to be able to discuss a variety of different options, whether it's surgery or treatment with the chemo or immunotherapeutics with people who do this, I think, on a very regular basis.
Okay, thank you very much. So here, this was the last question, and I would like to just finish with the take-home message from the talks, okay, which is that kidney cancer is a serious and treatable disease. It can be cured with surgery, and there are treatments that are now being offered to try to improve chances of cure even after surgery. There is a lot of hope in patients who have metastatic disease with the current available treatments, and experience counts. Here in the panel, you have experts in the field of kidney cancer who are here and will be very happy to help or to give opinions. As Dr. Sharma said, the telemedicine has been a significant help for patients who live far away and who want to get a second opinion, and that sometimes can make a difference. Okay, so we're gonna continue on with the symposium, and the next talks are very, very important and very timely. We will be talking about the emotional and psychological aspects and the impact that the kidney cancer has on the patient's emotions. We will be talking about a very important topic, which is clinical trials in kidney cancer, because research is what has allowed us to bring all the options that we have right now, how to manage side effects from the kidney cancer treatments, nutrition, and finally, a very important topic, which is survivorship in kidney cancer, like patients who have, for example, had surgery for curative intent. What's the next step? What do they do now? Or even patients who have, for example, a complete response to treatment. Okay, what are possible recommendations as to what to do next, which basically go beyond or outside kidney cancer treatment specifically. Okay, so we're going to start. Thank you.
Good morning, everyone. I'm really excited to participate in this educational symposium about cancer. My name is Maria Rueda Lara. I'm a psychiatrist specialized in taking care of patients with medical conditions, including cancer. Today, I'm going to talk about emotional and psychological impact of kidney cancer, what each patient needs to know. I assume that you are participating in this symposium because you or someone you love are fighting kidney cancer. The cancer journey starts with the discovery of a symptom or sign known to be a possible cancer indicator, like having blood in your urine. From this moment, the uncertainty of cancer begins. Could these symptoms mean cancer, or can I assume it's nothing? But this moment before the doctor has even called you or a single test has been done often transform a person's life from a general well-being and confidence to one of enormous anxiety and uncertainty about the future. This pervasive sense of uncertainty probably characterizes the journey with cancer more than anything else. It often lessens when things are going well, but is a feeling that never completely goes away. Uncertainty provokes anxiety, and it's normal to have feelings of optimism and despair that constantly change. Every person brings a unique characteristic to dealing with illness, a particular personality, a way of coping, a set of beliefs and values, a way of looking at the world. Research has shown that patients go through different stages when they're being confronted with a cancer diagnosis. The first stage, there's the denial and disbelief after hearing the news. The second stage, patients are overwhelmed to the point that it's difficult to take the next step. Patients realize that it's cancer. They feel restless. They cannot sleep at night. They feel helpless, hopeless. Their appetite changes. Patients eat too much. Patients do not eat at all. This period generally lasts 1 to 2 weeks. The turmoil is a normal response to threat and uncertainty. All of these symptoms, it doesn't mean that you are crazy. On the contrary, you are not crazy. After patients learn about their illness, there is a plan. And there is a plan. Patients adjust to the cancer diagnosis. For many people, a sense of relief accompanies starting treatment. I am doing something to fight cancer cells in my bodies. Studies show that works best is to deal head on with the issues of illness and treatment, seeing them as problems to be solved. There are patients who are in denial and refuse to deal with the diagnosis realistically and prefer to hide, which is not a healthy way of coping. After finding the diagnosis, now begins the time to coping with the actual treatment. What makes coping easier is having enough information about the treatment, its goals, and possible side effects. It's important to learn that information from a reliable source, not to go on the internet and find information that may not be realistic or not based on science. Having a caring medical team that is supportive and reassuring. Having a caring nurse who can interpret the doctor's communications. So if you go to the doctor and you're overwhelmed, and unfortunately we're not many times the best communicators, and we talk with medical terminology that may be difficult for patients to interpret. If you go to the doctor and then we tell you things that are difficult for you to understand, go back, call your nurse and tell them, could you please clarify what the doctor said? That may help if you're confused about what the doctor told you. Having support from others, having a belief system or philosophy of life that gives meaning to stressful situations. Seeking counseling to change behaviors or ways of coping that are counterproductive. What makes coping more difficult? Being a person who is generally negative towards life and its problems, unable to think one day at a time and worries about the future. Pessimistic by nature and can easily feel helpless in the face of stress. Have to try to avoid a challenge when possible. Prone to become nervous and distressed in the face of a challenge. Reluctant to persist in the face of stress and can easily become overwhelmed and feel hopeless. Unable to see the humorous side of negative things. The following do's and don'ts are intended to be common sense guidelines to help you avoid feeling trapped in the workings of a huge complicated machinery. Dr. Jimmy Holland from Memorial Sloan Kettering developed these for patients who have cancer. She was a psychiatrist who was married to Dr. Holland, an oncologist, and she heard her husband talking about cancer and the cancer treatment, and she realized that nobody was talking about the emotional aspects of cancer. So she became passionate about working with cancer patients and created the field of psycho-oncology. So don't believe that cancer equals death. With all the research, even though cancer becomes a chronic illness, there are new medications, new targeted treatments to cancer that gives the possibility of patients to live many years. And hopefully at some point we'll find a cure of cancer. Don't blame yourself for causing your cancer. Don't keep your worries or symptoms to yourself. Don't feel guilty. You cannot keep a positive attitude all the time. It is normal that after a day, after receiving chemotherapy, you can feel nauseous or have pain. It is normal to feel down and sad that day. It is okay. It doesn't mean that you're not optimistic or you became hopeless all of a sudden. It is normal. Allow yourself to have a day that you don't feel okay. Don't suffer in silence. Don't be embarrassed to seek counseling. Do use relaxation techniques. If you don't know, you can ask your oncologist to refer you to someone who knows that. Talk to your social worker. To find a doctor who lets you ask all your questions. It's important that you feel comfortable with the doctor that's treating your cancer. Do keep a personal notebook with all your dates for treatments. Do rely on ways of coping that help you in the past. Do cope with cancer one day at a time. So there are problems that require professional help, and those are when you're feeling overwhelmed by fear and distress, having feelings that get in the way to the extent that you're barely able to carry on your work, take care of you, family, and basic daily activities. When you have a change in your mood or mental function, that you are unable to function. For instance, depression is sadness that has become pathological. It is normal sadness that has become viciously disordered. Having a history of emotional problems. Having phobia to needles, if you are afraid of being in confined spaces, and then when you have to have a scan, or if you require radiation treatment, that can provoke anxiety. So you may benefit from seeing someone or taking a medication that is going to help you go through these treatments. Sudden change in mood or mental function during your cancer treatment. It is very common that if we're in pain, we take pain medications or we require steroids, that our mood changes and we can become more anxious or emotional. So if there's a sudden change, you don't have to suffer with these changes. There are medications or things that can be done to help you tolerate these emotional side effects from cancer treatment. There are physical symptoms that can cause distress, like pain, nausea, vomiting, fatigue, problems with concentration and insomnia. Talk to your doctor, and there's something that can be done about that, including with mind-body techniques or medications. When treatment situations provoke anxiety. Unfortunately, many of patients have losses during cancer treatment. Ask for help when you're going through something like that. Or when parents or other family members have died from cancer, or they also have cancer, and they're fighting cancer at the same time that you're fighting cancer. When there are memories that come back from a major trauma that you had earlier in life. I remember when I was in New York, I treated patients who were Holocaust survivors. And by being diagnosed with cancer, that brought back memories, painful memories from previous trauma. So what to do? Talk to your doctor. Keep in mind that certain medical conditions in cancer treatment can affect your mood. There are mental health professionals available to help you go through this. social workers, licensed mental health counselors, psychologists, or psychiatrists. What to do? There's talk therapy. You can choose a counselor that can provide that, as I said before, a social worker, nurse, psychology, pastoral counseling. And it's important to find a counselor with experience with cancer treatment. If it's not available, at least someone who's familiar with treating patients who have chronic medical conditions. There are different types of therapy: problem solving, supportive therapy, sexual counseling, individual therapy. If you prefer to be in a group setting and talking to others that are going through the same, consider group therapy, or even going to support groups. There are mind-body techniques that can help you go through the cancer treatment, like progressive muscle relaxation, deep breathing, meditation, guided imagery, journaling, art therapy, music therapy. There are also medications that can help you with emotional side effects or physical side effects. Medications like antidepressants, anti-anxiety medications, or stimulants. Many of my patients, they're afraid of taking medications because they believe that they're going to become addicted to medications. I mentioned that our medications for example, like mirtazapine, which is an antidepressant, but it happens to help with nausea, with insomnia, and increases appetite. Those side effects are beneficial for patients who have cancer. It is not an addictive medication. There are other medications that can help with energy and fight cancer-related fatigue. And these medications can be discontinued at any time. But again, they're like crutches to help you go through treatment. It doesn't mean that you need to be on a medication for the rest of your life. Medications also help with anxiety, poor sleep, depression, lack of concentration. And the goal of taking medications is to help with quality of life while fighting cancer treatment. So I'm really passionate about patient care. It has been a privilege to treat cancer patients during these years. Thank you all for participating in today's symposium, and I'll be happy to answer any questions. Thank you.
Hi, my name is Mario Belusic. I'm the GU medical oncologist at Sylvester Comprehensive Cancer Center in Miami. The topic of my discussion today, lecture today, is about clinical trials, and let's get started. So, as I said, the title is the clinical trials in kidney cancer. What are they, and are they good for me? So clinical research is a research involving people, and there are two main types. There are observational studies and clinical trials. In observational studies, researchers observe people in normal settings. They gain information according to growth characteristics and compare changes over the time. On the other hand, clinical trials involve studies that are aimed to evaluate a medical, surgical, or behavioral intervention. And this is a way to find out if a new treatment or new drug or diet or medical advice is safe and effective. In order for us to run the clinical trials, the clinical research, we need to have preclinical studies done. Preclinical studies are done by basic scientists, testing the drug or treatment in animal model or in vitro in a petri dish, understanding the mechanism of action, running the quality control tests and toxicology, and that is submitted to FDA. FDA is the United States Food and Drug Administration, who approves the drug for use for different diseases. However, FDA also has to approve every single clinical trial, and that clinical trial application is called NDA, or New Drug Application. And if the scientists of FDA and physicians of FDA found that studies in animal model have favorable results, the FDA will give approval for intervention to be tested in humans. So what are characteristics of clinical trial? Usually it's a medical or clinical studies. We need to find a volunteer or patients to participate. They last about 5 to 7 years. We need to obtain all the relevant governing and ethical approval of the different committees. And then investigators, as the physicians, are selecting patients based on the strictly defined eligibility criteria and enrolling patient in the study. There are 4 main stages or 4 phases of clinical research. The phase 1 is usually the testing drug on healthy individuals or on a cancer patient if we are talking about cancer drugs. And the goal of phase 1 trial is to evaluate safety, to find appropriate dose of a drug and possible side effects. Once the dose is established, the research moves to phase 2. The phase 2 is tested on up to 100 patients with targeted disease and looking for efficacy and further safety. Once drug shows some efficacy in the phase 2, the phase 3 starts, which is usually multi-center, multi-country clinical trial that enroll up to 1,000 or more patients and testing this new treatment compared to standard or approved treatment, old treatment. Once the data are collected, the drug application is submitted to FDA, and then FDA approves the drug if drugs meet 2 criteria, if it's safe and efficacious. The FDA does not discuss the cost of treatment. And the last phase is phase 4. Once drug is approved, the treating physicians report any side effects to FDA, and the FDA continues to evaluate drug for safety and efficacy. And in this phase, if drug is not doing well, or there are some new safety signals that are not recognized before, drug can even be taken out of market. So what is interesting to share this slide is that only about 10% of drugs going through phase 1 makes to approval to phase 4. 90% of drugs will fail along this line. So that is somewhat depressing or discouraging, but it's been like this for quite some time. And that's why we're doing lots of testing, trying to identify those drugs who can make it to the final stage or drug approval. Why patients should participate in a clinical trial? There are several reasons. One is give a patient access to new treatments before they are widely available. Patient can play a more active role in their own health care. That clinical trial helps researchers learn more about certain health problems. The research helps future generation of patients. Major medical breakthroughs could not happen without the generosity of clinical trial participants. And treatment options available today were clinical trial, evaluating clinical trials sometime in the past. So there is no way for us to move science forward, to move medicine forward without patient participating in a clinical trial. So once patient decides to go in a trial, what's happening? First, after patient expressed their willingness to participate in the trial, the study staff, including the research coordinator and principal investigator, will explain trial in detail and gather more information about patient. Once patient had all questions answered and agreed to participate, patient signs the informed consent form. Informed consent is a document that summarizes the reason why trial is done, the possible side effect, and what expectation patient has from the study team, and also study team has from the patient. Following that, there is a screening time when physicians and investigators run a series of tests to make sure the trial is good fit for this patient. And then if patient is accepted into trial, they schedule the first visit, which is baseline visit. The patient is then assigned to treatment or control group. And there are a series of visits after the patient starts the treatment when the investigators are collecting side effects, any issues or concerns patient may have or family members. There are regular blood work, regular imaging, regular safety visit, and patient continues to see your regular physician. Quite frequently, patients ask where they can find a clinical trial. The first step is to talk to your doctor or other healthcare provider about the clinical trial. The second option is go to clinicaltrials.gov. It's a requirement for every single interventional study in the United States to be registered at this government-run website. This government-run website allows you to search trial based on the disease, location, phase 1, phase 2, phase 3. So there are multiple ways using the keywords you can narrow down the search, and your provider, your doctor, can help you narrow down the potential clinical trial options for you. Each trial has a contact number and contact person, usually clinical research coordinator, that you can place a call or email, and that can start the screening and process for clinical trial exception. There is also some private companies. There's a registry or matching service that can connect patient trials in the patient area. There are some support groups and websites that focus on particular condition, and sometimes they share a list of clinical studies, and sometimes you can see advertisement on TV or a newspaper. Frequently, elderly patients, minority may say, like, why should we participate? Maybe this is just for younger patients, and it's not correct. The clinical trials really have to involve people of different ages, different ethnic backgrounds, because as we know, in order to drugs to apply to everybody, we need to have diverse clinical trial population. As people age, their body may react different to different drugs. The older patients may have many different doses or less drug of it, or may have different side effects. So it's really very important that clinical trials recruit people of variety of ethnic backgrounds and different ages. Having seniors enrolled in drug trials helps researchers get the information they need to develop right treatment for elderly people. What happens when a clinical trial or study ends? Once trial ends, the researchers collect the information, they analyze the data, and they present the data at scientific meetings or publication and submit the data to the Food and Drug Administration for the approval. Most clinical trials, they usually run as planned from the beginning to end, but sometimes trial may end before the end date due to many reasons. Some of the reasons may be that there are some unknown side effects that are experienced, therefore the trial was stopped ahead of time. There's a clear evidence that harms of treatment are greater than benefits, that leads to trial cessation. There is a problem with accruing the patient on the study, that enough patient cannot be accrued. There is a clear evidence that new treatment and intervention is effective or beneficial. So if trial shows the new drug is working much better than the old one, then it's unethical to continue the trial, and those trials are stopped early, drug is approved and offered to all patients. Or if new trial or similar trial show that new drug is effective, then the competing trial or similar trial may be interrupted early, because we already learned that a new drug or treatment is improved. The major problem in the clinical trial is that quite a few clinical trials complete. Here you can see the most common reason why clinical trials are interrupted. And the main one, about 40% of the trial, they are discontinued because we cannot enroll enough patients in the clinical studies. There are many other reasons, such as logistical issues or toxicity. But as you can see, the toxicity or adverse events are only in 10% of the cases. 10% of the trials are closed for that reason. Majority of trials fail or they close early because of lack of patients willing to participate on this clinical trial. And the main reason why some people are afraid to participate is safety. The people are frequently asking, are clinical trials safe? And I can assure you that clinical trials are very safe. Researchers, such as myself, are required to follow strict rules to make sure that participants are safe. The rules are enforced by the federal government. And there are two boards. There is institutional review boards. Each study site must approve every clinical trial in the United States. The IRBs consist of doctors, scientists, lay people who are dedicated to make sure that study participants are not exposed to unnecessary risks. Along with the IRB, most clinical trials are closely supervised by a Data and Safety Monitoring Committee. The committee is made up of medical experts who periodically take a look at the results of the study during the course of the study, and they decide to continue or interrupt or stop the study if the safety signals are notified. So, as I indicated, there are some challenges with a clinical trial, and one of the main problem is that what is quite interesting, that only 3 to 5% of all adult cancer patients enroll in a clinical trial. When you compare that with pediatric clinical trial in oncology, about 80% of pediatric patients enroll in a clinical trial. And there's definitely need for us to have more patients participated in a clinical trial, because without clinical trial, we cannot develop new drugs and new treatment options. Also, it's interesting that the same patients will sign up their children for a clinical trial, but once they have, or if they have a cancer later in their life, they may decline participating in the clinical trial. And that is something to think about, that, why we want the best thing for our children, why we don't want the same thing for ourselves. 70% of NCI-sponsored trials failed because of complete enrollment. It's more than clinical trials on previous slides I show you across the board. They are also sponsored by industry, because industry tends to have some additional ways to enroll more patients in the study. 20% of trials accrue no patients. So it means 20% of all trials, they have no single patient enrolled in the study. And 50% of trials are never completed, which is discouraging. And if we want to advance the development of drugs and find new treatment for a cancer patient, the clinical trial participation is really very important. So in summary, there are few take-home messages. Clinical trials are very, very important. They're very costly, but they're costly for sponsors, not for patients, because the drug provided on those trials, they're not charged to patient or patient insurance. They're very safe. They're very regulated and controlled. And as I indicated before, there's a U.S. Food and Drug Administration, IRB, DCMB, controlling every step of the trials. The trials offer additional treatment options in addition to standard options. There's a expanded way of treating the patient that are always something we have to talk with patients. The worst thing the oncologist can tell to a patient, there's nothing else we can offer. So having a clinical trials really help patients to have additional treatment options. Clinical trials the only way to develop new treatment for a given disease. And this is the only way to move science and medicine forward. I will conclude that as a physician, we have to take frequently exams, medical boards. And if the clinical trial is one of the answers on the medical board exam, this is always correct answer. And I can also say that it's not only correct answer medical board exam, it is also correct answer in the real life. So in summary, I encourage all patients to strongly consider clinical trial, to always ask their physician about the clinical trial. And if clinical trial is available, I will encourage everybody to participate. Thank you and have a great day.
Hello, everyone. My name is Ana Paula Harwood. I'm a nurse practitioner at Sylvester Cancer Center, and I am a nurse practitioner working with genitourinary cancers, especially kidney cancer. And I'll be talking to you a little bit about it today. So my talk is about identifying and managing side effects treatment in kidney cancer. For the last decade, a number of new therapies have been approved to treat renal cell carcinoma, causing significant progress in how we treat and manage this disease. Tyrosine kinase inhibitors, also called target therapies, are very important agents in the treatment landscaping of kidney cancer, because these agents target vascular receptors, resulting in blood supply deprivation. These drugs are cabozantinib, pazopanib, lenvatinib, axitinib, and everolimus. Immunotherapy, another very important treatment in kidney cancer, takes the brakes off the immune system, allowing T cells or antibodies to attack cancer cells. Some of the most used immunotherapy to treat kidney cancer are ipilimumab, nivolumab, pembrolizumab, and others. When selecting treatment for metastatic renal cell carcinoma for the first time, a criteria is used looking at patients' risk factors to determine best treatment response. Risk factors are classified into favorable, intermediate, or poor risk. For example, if patients are considered poor intermediate risk, treatment of choice are immunotherapy using ipilimumab, nivolumab, or pembrolizumab axitinib. If immunotherapy is not indicated, treatment can be used with cabozantinib, pazopanib, or even sunitinib. If favorable risk, combination therapy with pembrolizumab, lenvatinib, nivolumab, cabozantinib, or pembrolizumab axitinib are great options. For second-line therapy, any other option besides the first-line therapy, such as lenvatinib, everolimus, or cabozantinib, may be considered, or clinical trials. What are the patterns of immunotherapy toxicity? Immunotherapy is generally well tolerated. However, when breaks are removed from the immune system, it can cause T cells to attack healthy organs, besides tumor cells, a process referred to as autoimmunity. This process can cause inflammation in any organ of the body. The most common immunorelated adverse effects that can cause dermatological side effects are rash, vitiligo, dermatitis. In the gastrointestinal system, diarrhea, colitis, and even organ perforation. In the pulmonary system, pneumonitis, respiratory failure. In the hepatic system, which is the liver, transaminases, which is an increase of the liver enzymes, or even hepatitis. Endocrine, thyroiditis, which is thyroid inflammation, hypophysitis, which is inflammation of the hypophysis in the brain, adrenalitis, which is inflammation of the adrenal. Neurological system, it can cause neuropathy, meningitis, and even a very rare condition called Guillain-Barré syndrome. In the ocular system, uveitis, iritis, conjunctivitis. In the cardiac system, pericarditis, myocarditis. In the renal system, nephritis, renal insufficiency. In the musculoskeletal system, arthralgia, myalgia. Some of these immunorelated symptoms occur with less frequency, but may have serious consequences if they are not recognized and promptly treated. Because of time constriction, I will mention two immune-related side effects and how to manage them. An example is colitis, causing inflammation of the colon or intestines, characterized by symptoms of bloatness, cramping, pain. Usually, we recommend treatment with antidiarrheal like Imodium or Lomotil if the Imodium doesn't control the diarrhea. Hydration and dietary modifications, especially avoiding dairy products, caffeine, and foods that are spicy and or high in fiber. We can check labs for stool cultures, stool leukocytes, and C. diff to rule out any signs of infection. Sometimes we may even refer these patients to see a gastroenterologist to have a colonoscopy biopsy to rule out any inflammation or even any other problems. If diarrhea continues for longer than a week, oral steroids like prednisone is recommended. And the treatment is held until steroids are completely weaned off. Another example of autoimmune-related side effects is autoimmune endocrinopathies involving toxicities of the thyroid, hypophysis, pituitary gland, and adrenal gland. Hypothyroidism is a very common endocrine immune-related side effect, and is treated with thyroid hormone replacement. The occurrence of these immune-related side effects is low, with onset usually at 9 weeks after the initiation of immunotherapy. And the side effects may be fatigue, headache, vertigo, visual changes, changes in the mental status, and even hypotension. We may do labs to assess the thyroid hypophysis and adrenal gland, such as the thyroid stimulating hormone, the adrenocorticoid hormone, and cortisol levels. Consultation with endocrinologists may also be recommended to evaluate patients when there is suspiciousness of toxicities that are more serious. If hypophysitis is suspected, a pituitary scan or even a magnetic resonance imaging, an MRI of the brain, should be obtained to rule out any brain metastasis or inflammation. We saw how to manage immunotherapy-related side effects, and when toxicity is intolerable, treatment is held and steroids are initiated. Regards tyrosine kinase inhibitors, any treatment causing side effects are managed with medications and or lifestyle changes. For example, how to treat fatigue. Usually, fatigue is multifactorial. We look for labs abnormalities and correct them. We recommend physical activity with daily walks or light exercise to help to decrease the fatigue. If there is rash, we check the extension of this skin rash and treat with either emollients, hydrants, topical antibiotics, or even refer patients to dermatologists, depending on the severity. Hand-foot syndrome is a skin condition caused by callus formation in the sole of the feet and palms of the hands, causing skin thickness, blisters, and even pain. We recommend creams to exfoliate the dead skin, anti-inflammatory creams, special tools, and may need to refer these patients to podiatry. Hypertension. If hypertension exists prior to starting treatment, we continue doing a BP log, and we may maximize existing antihypertensive medication or add new ones to better control high blood pressure. Diarrhea. If there are 3 or 4 episodes of liquid stools a day, we recommend starting treatment with Imodium, increase hydration with fluids containing electrolytes, and diet modification. If not resolved, we may need to bring these patients in for labs and even IV hydration in our CTU. Stomatitis, which is irritation of the mucous membranes in the mouth, may cause dryness, redness, pain, blisters, and even cankers. We may recommend to avoid any mouthwash containing alcohol. Patients are recommended sodium bicarbonate type of mouthwash, such as biotin, and we may recommend and give a prescription of anti-inflammatory mouth rinse with steroid. Last but not least, proteinuria. We check urinalysis for a protein in the urine that may be caused by the treatment, kidney injury, uncontrolled blood pressure. If we can't control it and if the proteinuria continues, we may refer these patients to a nephrologist for further investigation. Side effect management is often complex and time-consuming, with some patients requiring significant support. Care of patients receiving these therapies requires a good understanding of the effects associated with these therapies. Moreover, clinicians caring for patients receiving tyrosine kinase inhibitors should provide resources, strategies, and interventions to maximize patient care. This includes telephone triage, patient and caregiver education, along with ongoing assessment of adherence and understanding of treatment goals. More frequently, visits to the office, labs, or telehealth visit for follow-up may also be required. And when I mention side effects of treatment, I not only the system to provide for patients who are treated with tyrosine kinase inhibitors, but also immunotherapy or a combination of both. I will give a case study example of to try to summarize a little bit of what I talked about now. So case study number 1 is about a 54-year-old woman diagnosed with metastatic renal cell carcinoma. The initial workup was done with a CT, which revealed a mass in the right upper lobe, which you can see in the first imaging, and the right renal mass, which you can see in the second imaging. We needed histology to better understand how to treat this disease. So an ultrasound biopsy was done of this right upper lobe mass and proved to be clear cell renal cell carcinoma. And according to the risk criteria, looking at labs, performance status, the time where this patient was diagnosed to time of starting treatment, this patient was found to be in the poor risk category, and the treatment of choice was ipilimumab, nivolumab. She did very well initially, but following 2 cycles of combination therapy, she started with complaints of increased fatigue, coughing, and shortness of breath on exertion. So she was treated accordingly with nebulizers, bronchodilators. She had the pulmonology follow-up. However, a CT of the chest to evaluate the cause of these symptoms showed that she did have some haziness or signs of that something was going on in her both lungs, as you can see by this CT scan. So a bronchoscopy was done by her pulmonologist, and biopsy confirmed to be pneumonitis. So treatment with immunotherapy was held, and patient was started on steroids with prednisone. 5 weeks later, this patient reported substantially improved coughing and was able to resume all her activities. Her oxygenation improved, and she was restarted on nivolumab therapy only. At this time, we decided to hold ipilimumab, and she did well afterwards. Case study number 2 is a 67-year-old male diagnosed with metastatic renal cell carcinoma to the spine. So a workup was done, and biopsy of this spine tissue was proved to be a clear cell renal cell carcinoma. Patient was identified as to be in the favorable risk, and we decided to treat him with cabozantinib 60 milligrams. There is a studies proving that cabozantinib works well in patients with bone metastasis. So patient was able to manage his side effects initially very well. He had grade 1 nausea and was treated with anti-nausea medications, Zofran, diarrhea, and fatigue. And he was able to manage all these side effects. However, after 3 weeks of into the treatment, he started with high blood pressure medication. And we start him on losartan 25 milligrams, but it was enough. The blood pressure continued to increase. Losartan dosage was increased up to 100 milligrams. So Patient did well for a while, and blood pressure was under control on losartan 100 milligrams. However, he started with headaches and described as it being the worst headache of his life. So an MRI of the brain was done, showing that he had brain metastasis. He was referred to radiation oncology. He received radiation. However, his BP continued to be elevated at 140/90s. So we decided to hold cabozantinib and wait until the blood pressure was back to grade 1 or his normal blood pressure medication. And cabozantinib here was decreased to 40 milligrams. Body scan before decreasing the cabozantinib to 40 milligrams, a body imaging was done showing stable disease, especially in the spine. So we decided to continue this patient on cabozantinib. Key points to take out of this is that combination therapy side effects may occur more frequently, earlier, and potentially at a higher grade than monotherapy. Tyrosine kinase inhibitors and immunotherapy, a combination of both alone and in combination, have significantly improved treatment options and outcomes in patients with advanced renal cell carcinoma. Immunotherapy side effects can affect any organ system. The absence of toxicity does not mean treatment is not effective. More common side effects associated with ipilimumab include colitis, hypophysitis, rash, pruritus. More common side effects of immunotherapy with Opdivo may include pneumonitis, arthralgia, hypothyroidism, and vitiligo. Side effects may occur as early as 2 to 3 weeks following treatment or after discontinuation of treatment. We have cases where patients were off immunotherapy and we still had cases of immune-related side effects. Side effects early detection are important for continuation of therapy and better quality of life. So it's very important that patients understand the treatment goals, how to manage their side effects to preserve their quality of life as well. So here is the DCC, the Dolphins Cancer Challenge, that happened in February 26, where we all collaborated to increase funds for cancer research. This is the end of my presentation. I hope you benefited from this talk, and I'm open for any questions.
Good morning, everyone. My name is Lori Bambaco, and I'm so excited to be part of this symposium, a celebration of hope. And I hope for my segment of the symposium to bring a little bit of nutrition hope to you. The title of my presentation is The Nutritional Management or Approach to the Management of Kidney Cancer. I am a registered dietitian, but I'm also board certified as a specialist in oncology nutrition, and really excited to be part again of the symposium. So on my agenda, I would like to briefly overview the role of nutrition in kidney cancer, and then also highlight cancer protective recommendations that consider how best to preserve kidney health. And then identify some simple solutions for symptom management. We call them nutrition impact symptoms, and they may impact your ability to eat the way you normally would hope to eat. And I have some solutions or suggestions for you to consider for that. And then lastly, I'll provide some of my favorite resources that I share with individuals to help support their nutrition care. So you might be asking yourself, when and how often should I meet with an oncology dietitian? And I like to say as early and as often as possible. But I think really the critical point is as soon as possible at time of diagnosis. I want you to consider consulting with a dietitian. Oncology dietitians can provide a comprehensive nutrition assessment, and from that assessment, we can curate a unique as well as a proactive plan, and that's really the name of the game in cancer care. But then during treatment, we want to reassess that initial plan. We want to make sure that we are optimizing quality and nutrient-dense foods as part of your care. And if there are any side effects that might come up because of treatment, we can address them and make sure we're still optimizing those nutrient-dense choices. But also after treatment in survivorship care, as well as palliative care, we know that a nutrition care plan matters. So we can help to promote healing from treatment and especially surgery. And then in palliative care to really improve longevity and quality of life through very intentional and pleasurable nutritious choices. So I want to first start with some goals related to nutrition and kidney cancer. The first is to maintain body weight, but especially lean body mass. And that also means muscle mass. I'm going to talk a little bit more about that. And that's all accomplished by achieving adequate consumption of calories, protein, as well as micronutrients, our vitamins and minerals. And no one single plan is the same. And that's why you deserve a thorough and comprehensive nutrition assessment from an oncology dietitian to be tailored to your specific needs. We are going to advise that you consume a kidney-friendly diet, which I will discuss this morning, and then again, modify that diet in case there are any nutrition impact symptoms that are present. So maybe you're wondering how much or what part of nutrition status is impacted because of kidney cancer. Well, unfortunately, before someone is diagnosed, there may already be a depletion of nutrition status. And this can, if it's not addressed early, this can result in muscle loss, weight loss, and potentially lead to malnutrition. It may compromise kidney health, which may lead to cardiovascular and metabolic concerns. And malnutrition is of an important significance. So malnutrition, if not addressed early, may lead to cachexia. And maybe you've heard about cachexia. An estimated 20% of all cancer deaths are related not to the cancer, but actually to cachexia. So the earlier an oncology dietitian can intervene, the better. So with all of that awful news, I have some good news to share. So nutrition counseling can help improve outcomes for anyone diagnosed with a kidney cancer. Oncology dietitians can help you retain your nutrient stores as well as your body weight and that precious muscle. We can help you improve your tolerance to your treatments and certainly to improve surgical outcomes. We can help you to restore and retain your kidney health and also especially promote healing no matter what the treatment type you may have had. And so this is a really nice statement from a recently published article just a year ago, and it highlights the critical value of nutrition in cancer care. The statement reads, oncology dietitians should conduct a nutrition assessment for every person with cancer. I couldn't agree with that statement more. Okay, so let's move on. What is recommended? What is both a kidney-friendly and cancer protective diet? Well, it's sort of, there's two things to consider that I want to emphasize today. The first is that it's abundant in whole plant foods. So we call them protective foods, and we're going to make sure we optimize as many of these foods into your day as possible. So that would include really a plant-based diet, and I'm going to talk more about that in a moment. But that emphasizes whole grains, beans and lentils, nuts and seeds, as well as fruit and vegetables. On the other hand, we're going to put some limits or even avoid excessive amounts of animal proteins, salt, as well as saturated fats. So we call them sort of like the harmful components that we want to minimize as much as possible. So that includes really ultra processed foods. I'm going to talk about that in a moment, as well as excessive amounts of salt, saturated fats, as well as red and processed meat. It's sort of my job to help make this doable for you. And I really have a lot of creative ways to make that possible. So what foods then are cancer protective and kidney friendly? I just highlighted these plant foods, right? And the way that I like to describe them is that they're cancer's worst food enemies. It's like what they do not want to see you put into your body. So why plant foods? Well, they are abundant in antioxidants, and antioxidants have been shown to help repair damaged cells. They contain fiber, and fiber is really an important nutrient. It helps us eliminate toxins, and it also helps us to control our blood sugars. Plant foods have a significant amount of phytochemicals, which I will speak about in the next slide. And plant foods also contain plant proteins. So they happen to be metabolized in ways that are protective for our kidneys. So I spoke about phytochemicals. They are what give power to plants and the plant-based diet. They really are, I think, one of the most important components that lend this protective effect for both cancer protection as well as preserving kidney function because of these phytochemicals found in plant foods. And that word literally translates to plant chemicals. They are unique compounds found only in plant foods, and there's literally tens and thousands of them that we know about. And they exert cancer protection on more than one way. They stimulate the immune system. They block the production of carcinogens. They help to reduce inflammation. They prevent and repair DNA damage. They slow cancer cell growth, and they also reduce oxidation, which is in our environment, and that sometimes may spur cancer development or the carcinogenic process. So let's move on to cancer protective recommendations that also highlight ways to preserve your kidney health and your kidney function. So one of the nutrition goals is to eat this plant-based diet. And I want to point out that a plant-based diet does not necessarily mean you need to be vegan or even vegetarian necessarily. But what it means is that most of your meals and your snacks contain whole grains, vegetables, fruit, beans, lentils, nuts, and seeds. So we know what it is. Why is it so important to try to eat a diet like this? Well, research supports that plant-based diets are far less superior for both kidney function as well as cancer protection. Plant foods have been shown to lower blood pressure as well as cholesterol levels. They improve antioxidant levels in the body, and they're also lower in calories. So when we're consuming mostly plant foods most of the time, research supports that this may help us maintain a desirable body weight. And did you know that overweight and obesity is associated with cancer risk? Actually, 13 different types of cancer, and kidney cancer happens to be one of them. So sometimes weight management is a part of the nutrition care plan for individuals. Now, you understand what the recommendation is. How can you possibly eat a plant-based diet? Well, I really like this image from the American Institute for Cancer Research, and they call it the New American Plate. And so hopefully you see sort of the proportion of the foods that are on your plate. And the idea here is that if you can design your meals to look like this most of the time that you're eating, you're often running to a plant-based diet. So 2/3 or more of the plate is occupied by plant foods, and then 1/3 or less of the plate by animal foods. Now, I would say, depending on who you are and what your motivation or resources are, you could even take this animal food on this plate and you could fill it with plant choices. So get your protein from beans or lentils, for example, as a substitution, maybe once in a while. Here are some other examples of how to pursue a plant-based diet. So I like to call this kind of the starter's guide. And the thought here is that you will gradually make some changes. Gradually replace some of your animal choices with plant sources of protein. Gradually replace some of the highly processed grains with some whole grains or even ancient grains. Include at least one, if not more, vegetable or vegetables at your meals. And could you consider fresh fruit instead for dessert? Now, if you're looking for some inspiration, I often like to recommend the Mediterranean diet as well as the DASH diet to pursue a plant-based diet. They aren't really diets per se, but rather they explain a style of eating or a way to pursue infusing your body with most of these plant foods most of the time. The next nutrition goal is to eat less fast food and highly processed food. So a little quiz question for you. What percentage of calories do we eat from processed food? I was surprised by this number, 60%. So 60% of the calories that we consume day in and day out come from highly processed choices. That's the majority, right? So what are these highly processed foods? Here's some examples on the slide: sugary drinks, cookies, crackers, chips, even breakfast cereals, and deli meat. And all of these choices are highly palatable. So because they sort of taste really good and are a convenient way to get a lot of calories without a lot of nutrition, we tend to eat a lot of them a lot of the time. And we even find that individuals who eat these foods most of the time have cravings for them. So we know what highly processed foods are. Why is it important to try to minimize them? Well, if we're eating 60% of our calories from these highly processed foods, that means we're not eating these abundant, whole, plant-based choices that we know to be protective. These highly processed foods are known to contribute to weight gain, which we know is a risk factor for kidney cancer. And most of these foods have excessive amounts of sodium as well as animal proteins, and that is not part of a kidney-friendly diet. So how to eat less fast food and highly processed food? I would say the first step is to try to unprocess your diet wherever you are able to. So I think of snack foods as often being highly processed. Could you snack on whole plant foods like nuts with fresh fruit, vegetables with a hummus or a guacamole, or even air-popped popcorn? And then consider cooking at home for yourself more often. When you do that, you control both quality and quantity of the ingredients, and you're bound to cook foods that have less salt, less sugar, and less saturated fats. Here are some other suggestions to unprocess your diet. I would suggest that you consider ways to flavor your food without those sugars, salts, and fats, and instead to use some herbs and spices. So whether it's something like turmeric or a squeeze of fresh lemon or cinnamon or even some vinegars, you're going to give yourself a pop of flavor, but also, again, maximize the nutrient density of your choices. And then consider some nourishing condiments. So the best example I can think of is to use something like avocado, mashed avocado or hummus as a replacement for some salty and fatty condiments that might be in your current diet. The next goal is to eat less red meat and processed meat. Another quiz question for you. So what percentage of us eat processed meat every single day? I was shocked to learn this one. So up to 74% is the current estimate. We are eating that much processed meat every single day. So we could do a little bit better. What are recommendations? Well, the experts advise no more than 12 to 18 ounces of cooked red meat per week. And depending on who you are, those goals might be modified even further. And there is no recommendation for amounts for processed meat. The experts want us to limit it if at all possible, meaning not eat it as much as we can. And examples of processed meat are bacon, ham, salami, and hot dogs. There's plenty of others, and I'm going to give you one on the next slide. So why are the experts advising this? Well, especially processed meat and the way some red meat is prepared are a problematic package. So they contain fats, proteins, and carcinogens that really equate with, again, this problematic cancer, potentially cancer-causing package. They contain N-nitrosyl compounds, heterocyclic amines, and polyaromatic hydrocarbons, which are known to be carcinogenic. And they often replace plant proteins, right? So we know that plant foods and plant proteins improve the complications of kidney disease, and we want to emphasize those instead of red and processed meat. So how do we do that? Well, I love this image from Meatless Monday, which is an amazing campaign I'll share on my resource slide. Processed meats put a strain on your kidneys and your life. That's no baloney. I thought that was cute. So really, that's a great example. How can we make some substitutions for something like bologna? So, first let's start with some of your favorite animal recipes. Could you simply make them vegetarian? So something like a bean burger or a vegetarian chili. And then I think of deli meat and deli sandwiches as being just a habit that we fall into. And could we make some substitutions with some whole food choices that are not processed? And the next recommendation is not to rely on dietary supplements for cancer protection. My last quiz question for you. Actually, I lied. I have one more. So what percentage of survivors use supplements? And this is an estimate. 80%. 80% of survivors, those diagnosed with cancer, are using a dietary supplement. So I bring this up because the medical team just wants to be aware of which supplements you're taking. The experts recommend that you do not consider dietary supplements as necessary to improve your kidney health or to benefit you for cancer protection. Why is that? Well, research shows that there's a lack of benefit for survivors. We don't see any role There are some exceptions at times, but we really don't see any role for dietary supplements as part of your cancer care. Dietary ingredients also do not offer the same benefits as eating whole foods. And actually, some dietary supplements may be nephrotoxic, toxic to your kidneys, or they may interact with some of your prescription drugs or even treatments. So again, just please share with your medical team if you're taking any dietary supplements. So how do we not rely then on dietary supplements for nutrition? Well, I have a lot of ideas, but just go back to that plate, that model plate where 2/3 or more, when you're sitting down to eat a meal or snack, has plant foods in it. As it turns out, these whole plant foods are a happy dose of vitamins and minerals. So we don't have to rely then on a dietary supplement. So for example, oats with some blueberries and almonds in the morning, or whole grain toast with peanut butter and banana. And lunch and dinner, these are vegetarian options like beans and quinoa with vegetables, but the sky's the limit with options here. You can even have, for a snack or even dessert, you can go plant-based, so yogurt or an alternative, and layering it in with some fruit and some quinoa. The last recommendation I want to talk about are nutrition goals. So some of the minerals that we could be eating in our diet, they may be out of balance in our body because of reduced kidney function. So I want you to discuss with your team if you need to consider reductions in sodium, potassium, and or phosphorus. And that's where a dietitian can help. Once you get those targets for limits, we can help you plan the diet accordingly. Now, the Salty Six, I want to talk about sodium and salt for a moment. The Salty Six is from the American Heart Association. Here's the top 6 choices in our diet where we find salt: canned soup, deli meat, breads and rolls, that might surprise you, pizza, burritos, tacos, and sandwiches, right? So highly, highly processed foods there. This, I promise, is my last quiz question. So what percentage does restaurant and processed food add for sodium to our diet? A whopping 77%. 77% of salt comes from restaurant and ultra processed food. So when individuals tell me they don't use salt in their cooking, I'm not so worried about that. The salt really is coming from these highly processed foods and restaurant foods. So when you cook at home for yourself more often, you are automatically going to reduce the salt and sodium in your diet. I also want you to ask about vitamin D goals. So vitamin D is the sunshine vitamin. And did you know this? We synthesize vitamin D, as it turns out, from UVB rays. We don't eat a lot of vitamin D. So 98% of Americans do not consume adequate levels of vitamin D in their diet. So this is why we just want to ask our team if they think our vitamin D should be evaluated. Now, here's an interesting study that I want to highlight for you today. Vitamin D has been shown to inhibit renal cancer cell proliferation, angiogenesis, clonogenicity, and metastasis. It has been shown to induce cell differentiation. And what the research study found, and this is a little dated, so we need a little more research about this, but the research study found that both high and low levels of vitamin D negatively affected survival. So again, a good question to ask your team if your vitamin D needs to be evaluated. So as a dietitian, I want to share some food sources of vitamin D. We find that food sources highest in vitamin D are from salmon, from fortified products like milk and dairy alternatives, also mushrooms if they've been harvested and exposed to UVB light, and the whole egg. So again, seek guidance about whether or not a supplement is recommended for you. Keep in mind that there is no single food, no single nutrient that is protective against cancer. It's the total diet as part of your protective lifestyle that matters. Okay, so lastly, I want to speak quickly about some solutions for symptom management. So the first one I want to speak to is about poor appetite. So if you are not eating or drinking well for 24 hours or more, please contact your medical team for evaluation. Now, if you are struggling with poor appetite, here are some solutions that I find to be the most helpful with individuals I work with. Rather than relying on their appetite, they actually schedule meals. So they use the clock as a trigger to remind them that it's time to eat. And every couple hours, they just have a little something. We want to just discover ways to infuse more nutrition into your meals and snacks. So even though it may be a small quantity that you're having, we're going to find ways to add calories and protein to improve the quality. That can be accomplished with vegetable oils or nut butters, for example. We may need to rely on some nutrition shakes and or customize some smoothies that would accommodate your taste preference and your nutrition requirements. I always encourage enjoying food with others, and that makes eating a little bit more pleasant. It may entice the appetite. Same goes for light activity. If you're allowed to be lightly active, we have found that this can help to stimulate the appetite. Next, I want to speak to nausea. And similarly, if you are nauseous and not eating or drinking much at all for at least 24 hours, contact your medical team. This needs to be evaluated. So here are my top solutions for nausea. I would say encourage yourself or your loved one to consume small, frequent meals. I find that anyone that delays or skips meals, their stomach is empty, and that actually exacerbates that feeling of nausea. We want to troubleshoot if smells or odors are a trigger for the nausea. I would say more often than not, this is really a game changer for individuals I work with. So we just find ways to really minimize the odor when a loved one is cooking for them, or we may prepare foods that are cool or at room temperature. I also encourage consuming liquids between meals, because if you are able to eat something, we really want to maximize the nutrition from some solid foods and not let the liquids compete with that. And really, we know this bland, soft foods are best. So things like hot cereals, white rice, crackers, applesauce, cooked carrots, broth, blended soups, plain chicken, plain eggs. And sometimes we explore ways to use ginger in some recipes that are really successful. Okay, and lastly, to discuss digestive distress. It's like a tongue twister. Okay, so for both diarrhea and constipation, I thought I would just give some simple tips on this slide here. So with both diarrhea and constipation, we want to think about fluid intake and make sure that individual is adequately hydrated. Certainly with dehydration, we want to make sure that with diarrhea, we want to make sure that individual is not dehydrated and they're replacing fluids and possibly electrolytes if they have diarrhea. If someone's constipated, I find more often than not, if they consume warm fluids, this will help to promote a bowel movement. And then also fiber. So there's different types of fiber in the foods that we eat, and they sort of function in different digestive ways. So the first is soluble fiber, and this is very helpful for those with diarrhea. So soluble fiber is found in foods like white rice, oats, bananas, and applesauce. And we will start there, but then we'll grow from there. So we might try some choices like chicken and white rice soup, or bananas with some peanut butter and some toast, and we really can expand from there. Now, what if someone has constipation? Well, we're going to use a different type of fiber, and that's insoluble fiber. So insoluble fiber is found in foods like flax seeds, as well as dried fruit and wheat germ. And this has been helpful to sort of promote peristalsis, which can help promote a bowel movement as well. Now, I will very often use food logs because everyone is unique. So we can find some solutions based on your specific food log and what you're eating and when you're eating to see where there could be some problems or some solutions for you. So this slide, this includes my favorite resources. I always share this with basically everyone I work with. So the American Institute for Cancer Research, Cancer Nutrition Care is a team that I am on, and we have a great website that's been updated. We have a lot of free screening tools and content for you to download for free. There are also some great websites for more nutrition information and then also recipes, if that's what you're looking for. So Cook for Your Life has some recipes that are specific to a side effect from cancer treatment. National Kidney Foundation has a whole section on their website about nutrition. Kidney Kitchen is great. So it has recipes that are tailored based on your unique needs, whether it be low sodium or low phosphorus. You can filter that to find recipes for yourself. Meatless Monday is an amazing campaign that is really promoting plant-based diets. And then I mentioned the DASH diet, which is the dietary approaches to stop hypertension. This diet has been clinically shown to reduce high blood pressure. So if that is something you have in your history or you're struggling with now, you may wish to visit that website as well. So in summary, I just want to review that nutrition is critical for every stage of the cancer journey. Nutrition counseling from an expert has been shown to improve outcomes. We know that personalized nutrition is greater than generalized advice, and it's my pleasure to help clarify that for the individuals I work with. And we also know that lifestyle matters, right? So a whole food, plant-based diet pattern, we know that it saturates the body with cancer protective compounds, and it also can preserve kidney function. So this is what we're really after when we're working together. And this is my contact information. Should you care to reach out, I would be happy to discuss your needs. And again, I look forward to sitting on the panel discussion to learn how I can be helpful to answer any further questions. Thank you.
Good afternoon, everyone. I am Frank Pinedo. I am Associate Director for Cancer Survivorship and Translational Behavioral Sciences at the Sylvester Comprehensive Cancer Center, where I also direct our Cancer Survivorship and Supportive Care program. It is a pleasure to be here today to have the opportunity to speak about cancer survivorship and kidney cancer, and I'd like to thank the meeting organizers for giving me this opportunity. I would also like to disclose that I'm a paid consultant for Blue Note Therapeutics, although that work is not related to the work that I'm going to be presenting today. So I would like to begin by saying a few comments in general about cancer survivorship. Cancer survivorship has received a lot of attention over the past several years for a variety of reasons. We have seen an unprecedented growth in the number of survivors. The National Cancer Institute and the American Cancer Society and other organizations term an individual as a survivor from the day of diagnosis and through the balance of their life. Survivorship care, in contrast, is the care we provide after an individual has completed primary treatment through the balance of life, and it includes the patient, the caregiver, the family, and the community. So with that definition in mind, we have seen this unprecedented growth where we currently have about 16 million cancer survivors in the United States, and that number is expected to reach about 26 million by 2040. Of course, early detection and treatment efficacy has played a significant role in this growth that we have seen in survivors. Unfortunately, the survivorship experience does come with several psychosocial and physical challenges. Through the cancer survivorship continuum from diagnosis through long-term outcomes, our patients experience levels of anxiety and depression that can impact quality of life. There is also uncertainty about disease activity and progression. Once patients begin to try to plan their treatment, they have to make difficult decisions, which are often complex and loaded with a lot of information that can create confusion and lack of understanding. Of course, once the treatments begin, whether it's neoadjuvant, primary, or adjuvant treatment, patients begin to experience symptom burden related to treatment-related side effects, which can lead to interpersonal disruptions. There's monitoring for the treatment response, making sure that the treatment is doing what it's supposed to do. There's a significant cost associated with cancer treatment. And of course, roles get disrupted, and role strain can also be a problem for individuals who are working, for mothers, or caregiving for family members. And of course, to the end of the continuum, we continue to monitor the cancer for activity, recurrence, or new cancers, and for late effects of treatments, which, as we know, persist well beyond the initial treatment period. So arguably, there's a lot of chronic stressors that are experienced by our patients and survivors throughout this continuum. We know from the literature that there's several factors that exacerbate or promote this level of distress, including disease severity, aging, premorbid function, comorbidities, limited access to care, health literacy, and information burden. Despite the fact that these experiences are prevalent, they're underdiagnosed and undertreated, hence the need for survivorship programs and survivorship care that has emerged over the past several decades. Also, there's a significant attention to patient reported outcomes, or the patient's ability to share their experiences, which can give us actionable data to help treat our patients. Just a few comments on quality of life. I will be mentioning that quite a bit today. Quality of life is a multidimensional factor or construct that consists of several domains, including physical function, social interactions, religious and spiritual status, economic status and factors, and psychological well-being. These are all impacted by the cancer experience in a negative way. The NCI and some investigators have coined the term a perfect storm, because not only do we have these challenges that are faced by our patients in regards to decision-making, depression, anxiety, symptom burden, monitoring their disease, but we also have other structural challenges which are on our horizon. For example, we have a shortage of oncologists and primary care providers that can provide competent, evidence-based care for survivors. There are deficits in provider knowledge, there are accreditation standards that we must meet, and there's significant care fragmentation, and minorities and disadvantaged communities continue to face limited access to care, which leads to disparate outcomes. So these are all areas that we continue to address to help improve or sustain quality of life in the cancer survivorship community. I wanted to talk a little bit about the symptom burden, which is something that we try to address to make sure that we can sustain and maintain quality of life. If we look at ambulatory patients that are referred to palliative medicine for symptom management, the symptoms that these patients are experiencing typically involve pain, anxiety, depression, fatigue, lack of appetite, nausea, and drowsiness. And you can see in this particular study, 50% or higher of the patient population experience these symptoms. If we look at individuals undergoing chemotherapy, which is, can be an invasive treatment with significant and chronic debilitating side effects, we see somewhat of a similar pattern with a significant number of patients, almost 50% or higher, showing elevated levels of fatigue, difficulty sleeping, pain, depressed mood, nausea, vomiting, and anxiety. I talked a little bit about disparities earlier, and when we look at depression specifically, we also see that depressive symptoms disproportionately burden our racial and ethnic minority communities. So the red bars here represent depression rates in individuals with cancer relative to those without cancer in Black, Latino, and as you can see in Black, Latino, and Asian population, those rates are significantly elevated. So given these challenges and the high degree of symptom burden and the fragmentation that we've had in care, the National Academy of Medicine, the old Institute of Medicine, has put together several influential reports which have guided how to work with cancer survivors. And they have given us three major tasks or mandates, if you will. One is that we have to address unmet needs. A lot of these symptoms that I discussed earlier are not adequately addressed. So we have to address the physical, emotional, social, financial, and care delivery needs. We also have to implement patient-centered assessments of psychosocial and physical symptoms so that we can capture these experiences and work with the patients effectively to reduce that burden. And finally, we have to avoid care fragmentation via coordinated survivorship services. We want to make sure that once the patients get all the attention they get, rightfully so, during primary treatment, that care is coordinated in a way that they continue to get care to address their symptoms. So we have a series of accreditation standards that we have to live up to. We have to conduct psychosocial distress screening and document referrals for these various conditions that are listed here. And we have to have a comprehensive survivorship program in place, which addresses prevention of recurrence or secondary cancers and surveillance for those cancers, coordination of care, and intervention that addresses the needs of our survivors. Excuse me, shifting now to kidney cancer survivorship. So I know most of you know this information, but it's always good to recap. We know that these are the 6th and 9th most common cancers in men and women. It is not in the top 10 leading causes of cancer deaths. Annually, there's about 77,000 diagnoses of kidney cancer, and the rates are increasing. We think part of that is due to advances that we have in imaging and better detection of kidney cancer. Annually, we have about 14,000 deaths. And if we look at the 5-year survival rate, it's highly variable depending on disease status. So in general, the general kidney cancer population has about a 75% 5-year relative survival, meaning that 75% chances that the individual will be alive 5 years after diagnosis. But that rate varies based on whether the disease is localized, regionally advanced, or metastatic. And of course, in metastatic disease, we have a lower survival rate. Several factors have been listed as risk factors for developing kidney cancer, such as smoking, male gender, Black race, having hypertension, kidney disease, dialysis, and a family history. And surgery, radiation, and targeted therapies and immunotherapies and chemotherapies are common treatments that are given in kidney cancer depending on the stage and the disease severity. And we know that the side effects can vary significantly by treatment and disease severity, but they're quite vast. This graphic here, I'm not going to mention all of these, but as you can see, all sorts of symptom burden can emerge depending on the treatments that the patients are receiving. And as you can imagine, these can be debilitating to our patients. So what do we know about quality of life following treatment for kidney cancer? Well, unfortunately, I have to say that relative to other cancers like prostate, breast, colorectal, melanoma, the work that has been conducted in kidney cancer and quality of life, psychosocial adjustment, and survivorship is quite limited. And it's limited in several ways, which I'll mention in a future slide. Here we have a study that looked at individuals from baseline through a 12-week follow-up right after treatment. And these are patients that received treatment right after the baseline assessment. And what we see is we have a significant drop in general function, significant drop in pain, which is a good thing, although it creeps back up soon after treatment, significant drop in gastrointestinal disease symptoms, and in activity and physical function composite from the SF-12, which is a general measure of quality of life and functioning. And if you see the red and the blue lines, these represent either radical or partial nephrectomies. And we don't see a significant difference across these two procedures. What we see is an equal pattern of a decline in quality of life across the board, again, for general quality of life, physical activity, physical functioning. Surprisingly, despite the symptoms that we see, the mental health composite of the SF-12 doesn't seem to be impacted. If we look at post-surgery with curative intent, so these are typically early stage or earlier stage patients. This is a study that looked at prostate, kidney, and bladder cancer. These are the graphs for kidney cancer. We find that relative to age-matched controls, at the 1 to 2 year mark, we see significant drops in physical function, role function, social function, but we see a rebound after a 2-year period, which is good news because it tells us that the effects of treatment tend to be time limited and that patients tend to recover relatively well after that. And in terms of general quality of life, we see the bump right after treatment. And in fact, it's higher than what we see for controls. And this is consistent in a lot of the cancer survivorship literature. In terms of support that patients get, we also see that patients right after the treatment in that 1 to 2 year and the greater than 2 year period, they get greater levels of effective support and confidence support from their family and friends. This is a relatively small sample study, but it does highlight the variety of symptoms that are associated with treatment. These are individuals who had either localized in the dark bars or metastatic disease. And as you can see, a significant number of symptoms, including pain, weakness, fatigue, hair loss, sleep disturbance, GI and urinary dysfunction, and emotional symptoms like worry, irritability, and depression, and memory symptoms. And many of these were reported by a third or more of the sample. Small sample, but a nice distribution showing what these symptoms look like. One area that I'm not going to talk much about today, but I did want to mention at least briefly, is the concept of financial toxicity, which is getting greater attention in the survivorship world. And this is where an individual is impacted by the cost associated with cancer, where they have significant material strain and burden specific to medical debt and reduced lost income. They have a psychological response aligned with that, which involves financial worry and distress. And then they engage in some coping strategies, which are not useful, but at times necessary for them to maintain a decent level of functioning in their day-to-day lives, specific to their finances, which can include skipping medications or missing physician visits. There's a whole new set of studies that are actually looking at how to address this and how to manage this financial toxicity, which is getting more and more attention. So how can we intervene and improve quality of life? So let me shift gears a little bit and say, okay, so we have quite a bit of research that has supported approaches that can improve health-related quality of life in cancer patients. And these tend to include either targeted behavioral and psychosocial interventions or health system-based interventions to help patients. And what I'd like to do, I'd like to talk about two areas of work that I have been involved in for quite a few years. One is the delivery of cognitive behavioral stress management. These are cognitive behavioral therapy-based stress management techniques that help patients cope with disease activity, worries, anxiety, and other factors, and are delivered in a group format to our patients. And the other area is a health system-based program called My Wellness Check, where we use the electronic health record to conduct an assessment and triage patients to the right resources. So let me start with the CBSM, the Cognitive Behavioral Stress Management Program that we've developed and delivered. So this is our conceptual model. We know that cancer treatment and associated circumstances can create a significant level of stress in our patients, caregivers, and families. And this stress presents several psychosocial treatment targets that can be targeted through cognitive behavioral therapy and other therapeutic techniques, including relaxation techniques. So we provide to these patients, we bring them in a group so that they can relate to one another, talk about the commonality of their experiences, and we provide them with anxiety reduction skills. We change negative thinking, build effective coping strategies, facilitate emotional expression, reduce social isolation by promoting social support, and reduce risk behavior, whether it's specific to smoking, physical inactivity, or lack of proper diet. And the idea is that if we can bring individuals together and target these areas, that we're going to improve emotional and behavioral adaptation. So we're going to have better mood and social relations, reduce anxiety, improve treatment compliance, and improve health behaviors. And that's going to be related to a series of physiological effects that lead to physiological adaptation. So better endocrine and immune regulation and other physiological mechanisms. And collectively, these will lead to better quality of life outcomes and other health outcomes. So that's our intervention model in conceptual model. And of course, these interventions vary depending on disease-related factors, and intervention for somebody with early disease is very different than for someone with metastatic disease. We also look at socioeconomic status, health literacy, and other factors like culture to address how we format and deliver the intervention. So if you think of what drives adjustment to cancer, we have the social context, which are factors that are difficult for us to change. So access to care, health literacy, financial strain. We have the clinical context, which tends to be a consequence of these other factors. So limited screening, late presentation, more disease severity, and comorbid disease for patients that have a disadvantaged social context. But then we have factors that we know can promote quality of life. And these are modifiable factors that we tend to target in the intervention that I mentioned, like knowledge, adaptive emotional expression, coping, optimism, social support, etc. So the idea is, can we promote these factors to buffer the stress and the effects of cancer and quality of life? So the intervention is very straightforward. There's 4 major domains of cognitive behavioral therapy. It's increasing awareness of how stress affects the individual. It could be physical, emotional, cognitive, or social. We help the individual change negative appraisals, so getting rid of negative thoughts, refuting and replacing irrational or negative thoughts. We help them build effective coping responses, whether they're direct or indirect responses, and execute the necessary steps to effectively cope with the stressor. And we help them identify good sources of social support so that they can benefit from those sources. And then we also have a relaxation component to reduce arousal, which involves deep breathing, progressive muscle relaxation, guided imagery, and meditation. We've been successful at delivering these interventions also, again, primarily in prostate and breast cancer through the web, which came in very handy during the COVID pandemic, where we've developed very simple, easy-to-use platforms that help patients navigate through a web-based program that can be delivered using a Zoom interface with a therapist and up to six to eight participants in each group. And these platforms are very useful because they can, the participants can access the relaxation videos, expert videos. They can access weekly reviews of the content of the intervention. And of course, they participate in a weekly online group. These interventions typically last 10 weeks, about an hour and a half to 2 hours per week, but there's a little bit of variation in that depending on the program. And this is just another interface of the tablet for the cognitive behavioral stress management condition, which provides the sessions with a live interface or an interface to review the material and the relaxation sessions. So what we have been able to manualize and publish these interventions for community audiences. We've had a series of key findings, which I don't have time to go through each of them, but we have enough of an evidence base to be able to promote these interventions as interventions that could benefit and improve quality of life, at least in prostate cancer and breast cancer. Another way that we can intervene and help our patients is through interventions that are embedded within the health system. And these are a little bit different. These are not recruiting a group of participants to be within one group setting with a therapist, but this is rather assessing and intervening for the specific needs that the patients tell us they have. And this falls in line with a lot of interest in patient engagement and optimizing the advances that we have in technology so that we can assess the patient remotely through reminders through the patient portal, have that information feed back to the electronic health record and to the provider so that we can triage the patient to the right level of care. And ideally, of course, what we want to do is make sure that we have the best outcomes that align with these best practices that are driven by assessment and intervention within the electronic health record and the patient portal. So there's a lot of information here, so bear with me just 1 second. But part of the intent here is that we're using very sophisticated measurement assessments. We use PROMIS tools, which have been funded and developed by the NIH Common Fund, and use computerized adaptive tests to measure in a brief and concise manner a variety of domains. And we're able to obtain information on practical needs, psychosocial needs, or needs specific to physical activity, nutrition, and cancer rehabilitation. All of this is collected and scored in real time when the patient fills it out through the patient portal, and alerts are generated to route the patient to the right resources that may be beneficial to them. This is the schematic of how the system works. So first we look at patient eligibility. We always start at the second visit or later, and the patient has to have the ability to log on the patient portal. We have a monthly prompt where we send the patient an alert letting them know that they have an assessment that's ready for them to complete. We do it via text, email, or call, depending on the patient preference. And then we provide the e-health assessment through the patient portal. We do have an at-clinic solution or assessment, but due to COVID, that's been placed on hold until further developments. But via that patient portal, we assess anxiety, depression, fatigue, and pain and physical function. Remember that these are some of the same domains that our patients and kidney cancer patients report as being problematic. But in addition to that, we also assess nutritional needs, practical needs, rehabilitation needs, and we measure quality of life as an outcome. Practical needs are typically needs specific to transportation, financial counseling, or need for stress management. Rehabilitation needs are needs more specific for physical rehabilitation. All this is scored in real time, and there's no alert. We reassess the patient in 30 days. We never do this more than once in 30 days, so we don't overburden the patient. If there is an alert, either social work, nutrition, rehabilitation, medicine, or the medical team gets a best practice alert, letting them know that the patient has an elevated or problematic score and that attention needs to be given. And then the provider is expected to code a disposition in the electronic health record. So here we have a couple of areas that are of benefit to us. Not only are we incorporating these PROMIS CATs to address constructs that are difficult to measure and are often underdiagnosed and underassessed by clinicians, but we're also meeting Commission on Cancer standards of accreditation so that we're assessing patients, particularly for anxiety and depression. Excuse me. This is what the patient portal looks like. This is a web shop, but it's also mobile friendly. We only do one item at a time on the screen to keep it simple. This is an assessment for anxiety and anxiety CAT. This is an assessment for the practical and psychosocial needs. And these assessments populate in real time in the EHR. This particular mock patient has had difficulty with physical functioning, and that shows here in red with exclamation points. And we can also track the physical function scores of these patients over time. And unfortunately, this patient has been decompensating over time. But in essence, the EHR has all the information we capture, and the provider can click in any of these and look at the specific items that the participant completed. So what about our kidney survivors with clinically elevated scores? So what we're seeing within our health system, depression being prevalent, and again, this is clinically elevated, meaning this is problematic and the patient needs to have further screening. 14% of our kidney survivors is depression, about 10% anxiety, and about 4% pain. These numbers are not as high as you would expect because remember, these are patients that have been coming into our health system. It could be they were just treated, or it could be that they've been diagnosed for several years and they have adjusted well. But nonetheless, these are significant, particularly for anxiety and depression. When we look at needs, what we see is, interestingly, support to help me cope with my cancer. And this is a challenge in kidney cancer because, again, unlike breast, prostate, and other cancers, we have not done a great job at developing interventions and programs that specifically target these patients. Also, financial concerns and general cancer education were the second and third most listed needs. So some conclusions and next steps. So we have evidence that a subset of kidney cancer patients and survivors have compromised health-related quality of life. But as I mentioned earlier, we do have very limited research in this area. Typically, we have small samples, limited follow-up, and lack of racial or ethnic minority inclusion, and this tends to limit the number of patients who really are severely disadvantaged and need help. We have a vast amount of research that supports the models of these interventions and programs to promote health-related quality of life, but as I mentioned, mostly in prostate and breast cancer. So we do have a critical need for more comprehensive assessment and understanding of what are the specific patient experiences, what are the determinants of optimal clinical and psychological outcomes in this population, and how to intervene, particularly at various stages of the disease. And this needs to happen in larger sample sizes with longitudinal follow-up, and we just don't have conclusive or definitive data for kidney cancer in these areas. So again, large samples with long-term follow-ups will help us identify determinants of adjustment, and particularly important, what are some of the modifiable factors that impact quality of life that can be targeted via interventions. And hopefully we'll be seeing more of that work here at Sylvester and other cancer centers. I'd like to thank you for giving me the opportunity to present in this work in survivorship and in kidney cancer, and particularly thank the organizers for giving me this opportunity. Thank you very much.
Hello, I don't know if you can hear me. I apologize for these technical issues. Dr. Bilusic, can you hear me?
Yes, I can hear you.
Okay, so I don't know if there have been some questions answered already.
I haven't seen any question for the second session. For the questions were just for the first part that we already addressed, but for the new one, I haven't seen any. So
yeah, so there were some questions from the private chat here that were passed on, and I wanted to read some of them. One of the questions here was if there was any tests that patients can undergo before immunotherapy is started, and or to see if the patients might respond to treatment. So this is a question about, are there predictive markers that we can use? And I would like to start with Dr. Bilusic addressing this question.
Thank you, Dr. Mercian. So, biomarker discovery is a very lengthy process, and there are two types of biomarker. They're predictive and prognostic, means that if patient has certain marker, they can predict how they're going to respond or what the outcome of the treatment will be. So, for the immunotherapy, there are some that we are, considering for not necessarily for kidney cancer, but in general, like, if tumor mutational burden or things like that. But for a kidney cancer, there is one that is validated that we use in order to decide which patient will be given immunotherapy. So currently we are considering everybody for immunotherapy if there is no medical contraindication that may not be safe for certain drugs to be given to a patient.
Okay, thank you. There was another question here on cabozantinib that say many people on cabozantinib start at higher doses. The usual dose as a single agent is 60 milligrams, okay? And when it's in combination with immunotherapy, it's usually 40 milligrams. But the question is that, so patients who start at higher doses have bad side effects and then have to lower the dose or even suspend the treatments. So the question is, why not titrate up and start at the lower dose, like 20 milligrams, and see how the patient is doing, and if lower dose is leading to any good results? So I will try to answer that question. Usually, the FDA approved doses for cabozantinib are the ones that we mentioned, 60 milligrams as single agent and 40 milligrams in combination. And one of the reasons why these doses are used at the beginning is because there are studies, and it has been shown that the efficacy of the treatments with these targeted therapies is related to the dose and to the concentration that the dose, when patients take the medication, reaches in the body, right? Obviously, higher doses have been associated with higher efficacy in many cases, but also with higher toxicity. 20 milligrams is a dose, I also would say the lowest dose of cabozantinib that is feasible. And sometimes when patients go so low to that dose, the efficacy may sometimes be compromised. So what is critical, and this would be a question for Anna Harwood, would basically be like what would be critical is the early identification and early treatment of those side effects. So I wanted to ask you, Anna, what do you think are the most important factors to try to keep that balance between the efficacy of the medication and the side effects?
Thank you, Dr. Mishra, for that question. Yes, I agree. We have to start on the dose that is indicated by evidence-based research, which is 60 milligrams for single agent, 40 milligrams with immunotherapy. The main goal here is to keep patients in treatment and also help them to deal with side effects. And one of the main reasons to deal with side effects, I believe, is to help them understand what the side effects are and what they can do to help to control it, manage it, and have their quality of life. Obviously, they wanna be treated, but they wanna do what they wanna do on a daily basis. So it's important to understand that cabozantinib has many side effects, but they can be managed. Obviously, when they are not managed and they get to a grade that intolerable, then we have to sit down and talk and see what we can do in terms of reducing those, in terms of give them breaks. That's another possibility too before we reduce those, and keep patients in treatment.
Thank you. Now, I would like to ask a question to Dr. Rueda Lara and Dr. Pinedo, which basically have to do with the emotional, psychological issues and also survivorship. First, is like given the significant stress that patients with metastatic renal cell cancer have, and many of them may need help or not. One of the questions that patients ask is, do all patients who have these emotional challenges, emotional dysregulation or psychological issues, do all of the patients need to see a psychiatrist? Or what is this a stepwise approach? How are these patients addressed and managed in terms of who do they need to see, a psychologist, a therapist, or a psychiatrist, and who, how the patients can be guided in that regard? And second, what are the resources at Sylvester that are available to help patients with cope with these issues like stress, issues like this health-related quality of life that patients may or may not be aware of and can use here at Sylvester? So I think that the first part of the question is to Dr. Rueda Lara. The second question would be for Dr. Pinedo.
Okay, so when somebody's dealing with emotional or psychological symptoms or distress, I think the first person that you should contact would let know is the oncologist, the nurse practitioner, and the social worker that works with the medical team. The social worker should meet with the patient and assess what type of distress, because there are different needs that the patient, there are different causes of patient's distress. Could be financial issues, could be side effects from the medications. They could be having like a loss in the family. So the social worker should be able to direct the patient to refer them to a psychologist or a psychiatrist for support. Not everybody who is dealing with emotional symptoms, as I mentioned in my talk, needs to see a psychiatrist and take medications. But the first contact should be the oncologist, ARMP, and the social worker. At Sylvester, I work with 2 psychiatrists and 3 psychologists, and also we have about 29 social workers. And in addition to that, I'm part of Cancer Support Services, and we do have our therapy, music therapy, exercise physiology, chaplaincy. There are other resources that we have to help patients with any psychological or emotional distress related to cancer.
Thank you. Do you have anything to add, Dr. Pinedo?
Yeah, I think, so thank you, Dr. Rueda Lara, and she answered, I think, what I was going to answer about support services, but I think it's also important to understand that most cancer patients do adapt relatively well to a cancer diagnosis and its treatment and the treatment trajectory. We do have a subset, about a third of them, that have those clinically elevated levels of distress. And just as important to treating those, it's important to assess. Like Dr. Rueda Lara said, typically the best approach here is for the patient to inform their medical team providers so that they can route them to the right services. But not all patients are willing to endorse anxiety and depression or distress, or it might be a feeling of shame or feeling weak, or maybe feel under pressure that they have to be strong throughout this experience. So that's why programs that systematically assess these domains are so important. The other thing is that a lot of patients undergo what we refer to as adjustment disorder, which is more of a transient experience where they may have clinically elevated distress, but it does resolve after time. So I think that's the only thing I wanted to add. But in general, we have a very robust cancer support services program that has a variety of programs available to patients and survivors.
Thank you. And I would like to ask a question to Lori. Lori, fantastic talk. It was incredible. Thank you very much. It was very, very informative to our patients. And I completely agree with you, and I like your emphasis on the importance of diet, both to treat symptoms of the disease and also to try to protect the kidney. And as Anna probably knows also, the plant-based approach was like music to my ears. And this is very important. What I wanted to ask you is like, from your experience in terms of when you talk to your patients about nutrition, what is the level of acceptance from patients when you counsel them to modify diets, to focus more on plant-based? And do you see a lot of acceptance, a lot of resistance? And what are your strategies to try to guide the patients through kind of like improve their diets?
Thank you, Dr. Marchand. That's a great question. You know, my job as a dietitian, first and foremost, is to understand who I'm working with. And so that requires a thorough and comprehensive assessment that also includes their motivation. And I would also say that I have a passion for oncology nutrition because I find that many individuals are highly motivated because they find that food and nutrition is an opportunity to empower themselves. And I always look to respect and preserve that for individuals. And I feel fortunate that plant-based diets are very trendy right now. So there's a lot of talk about them, and there's a lot of products that are available. I think even you'll see on restaurant menus, you know, there's really this momentum towards the shift of plant-based eating, and that makes my job a little bit easier. But I find that, you know, in general, I start where the patient is at. So some individuals are highly motivated, have resources, already are eating plant-based, and we're just going to look for opportunities there. While on the other hand, I may have individuals who are reluctant, you know, and I have to just build rapport with him or her and understand what might motivate them, and also help partner with them. You know, I always share that it's not my responsibility to tell someone what to put into their body, but really help them make the best decision for themselves. So it's challenging, but I have a lot of fun, and I find that that's the most effective approach.
Thank you very much. And I don't see any further questions in the comment section, but I wanted to ask a question to Dr. Bilusic regarding clinical trials and clinical research. So from your talk, and it is well known as well, that the percent of patients who go to oncology clinics and the oncologists who participate into clinical trials is extremely low, right? And we want it to be much higher. What do you think are the biggest barriers to clinical trial participation maybe at the patient level, and also and importantly at the provider level? And what do you think we can do to improve these metrics, the numbers of patients who participate? Because we all agree here that clinical research can cure kidney cancer, and many of the treatments that are available have been the result of clinical research.
A great question, Dr. Marchand. So I think one of the major barriers is a lack of knowledge. So I think we as a physician, we're supposed to be teachers and try to provide information to patients. And lot of patients, the concept of clinical trial is very complicated. They're testing some new drugs, and then they're always afraid that there's a placebo or sugar pill somewhere else, and then that the treatment will be not safe, or they may have some side effects, and it's unknown. And it's a lot of resistance people, because as we know, unfortunately, there are some bad things happening in the history, not so even in the 60s and 70s, that there were some not very ethical things done with the research. So there's a lot of resistance, particularly in the minority population, that they think that maybe we are doing some unsafe practices. So I think education is the key, providing and reassuring patients, and then helping patients to initiate discussion and to give them, talk to your doctor about the clinical trial opportunities. Many, unfortunately, in the community, there are not so many clinical trials available because that's expensive enterprise to run a clinical trial. So, there's also, lack of the knowledge among the, community of physicians, that they may not know what is available. So I think education, both at a patient level, at a physician level, and among the oncologists, and providing resources to patients, trying to match them with the best clinical trial, because as we know, clinical trials, they come and they close, and slots may not be available. And just going to clinicaltrial.gov and searching for clinical trial, even I found something very challenging for finally looking for my patients. So I think, with the artificial intelligence and having maybe access from electronic medical records to database, so maybe computer can help us search through database and see what is the closest clinical trial. There's a patient can match the criteria and participate. So I think it's a work in progress. I think we are getting better, but there's definitely a lot of things to improve.
Thank you very much. And one final question, Dr. Pinheiro, I was intrigued by a part of your talk where you discussed about patient reported outcomes in terms of like a tool to try to improve care and improve health-related quality of life. Can you expand a little bit more, and so for the patients to grab this concept, and how and what would be the potential benefits of these patient-reported outcomes, and how that will help them, and how they would help the physicians taking care of them?
Sure, thank you, Dr. Marchand. So over probably the past 10 years or so, there's been quite a few studies that have documented that the patients tend to do a much better job than their clinicians at rating their symptoms, particularly for symptoms that are vague and difficult to operationalize, like fatigue, depression, and pain. So that has led to a lot of interest in how do we capture these patient-reported outcomes and then use them to help the clinicians guide and manage the clinical care. Also, studies have looked at ratings of symptoms by patients versus clinicians, and again, clinicians tend to underrate the symptoms. Of course, this is not to be harsh on clinicians. We know the challenges of a brief encounter with a patient and the pressures of clinical management. We also know from our clinicians that we query that the focus of their encounter, rightfully so, is disease activity, progression, remission, medication management. So there's really very little time left to talk about these other issues that are brewing in the patient's life. So the NIH and other investigators have developed a really good set of measures that are as easy to administer. They can be based on a patient portal on the websites for patients to do their own self-reporting. And again, that can help the clinicians manage these other symptoms.
That's great. And what I hear is that it seems that here at Sylvester, we have all these tools potentially available or realistically available for the patients and clinicians. And this, I think, should be something that we need and we will work on for patients with kidney cancer. I also was impressed by the fact that there's not a lot of data of this in kidney cancer, and I think we can and should start this effort at Sylvester with our patients, and that can extend to the satellites and other centers as well. So I think that's great.
Absolutely.
Okay, so I think there are no further questions, and knowing that we are a little bit late, we are going to continue to the breakout sessions. From what I heard from Linda, seems that the breakout sessions are for patients or for caregivers. And I'm not sure if Linda is on, who or may want to give some instructions in terms of how to join. Or, but what I heard is that this is mostly for patients and healthcare providers. So I would like to thank all the speakers again for this incredible morning. This has been another successful Kidney Cancer Symposium. Hopefully next year we will be able to do it in person again. And thank you for your participation and for the excellent talks. Thank you very much. Thank you.